Good morning and welcome to this meeting of the North East and North Cumbria Integrated Care Board for the 25th of July 2023. I'm Liam Donaldson, I'm the chair of the board, and everybody's very welcome, those who are here today and those who are watching online. I have a few announcements to make before we start into the agenda. First of all, to announce that we have two new members of the board replacing outgoing members. Representing Health Watch, Christopher Ackers-Belcher will be our regular participant member in that category. He's not able to come this morning, but obviously we will look forward to seeing him at our next and all future meetings. And then representing the voluntary and community sector, Lisa Taylor is here, and she is from the organisation that we know very well, VON, and she will also be a regular participant member of the board. We also have apologies from one of our partner members, Tom Hall. And then finally, I'd like to just express our gratitude to Aja Zahid, who is leaving from his post as Executive Director of Innovation to take up a new post overseas. So thank you, Ajaz, for your work while you've been with us, and we wish you luck for your future role. We are quorate as a board, so it's in order for us to start the meeting properly. And then if I could just ask if there are any declarations of interest which are not in your published schedules for this meeting. Graham.
Thank you, Chairman. Just agenda item 11, just to declare a previous declaration that my son works for the ambulance service, just for transparency purposes. Thank you.
And then when we come to the dentistry item, Hannah, you previously declared you have a family member working in that field.
Yes, that's right.
Thank you. Right. Now, so we turn next to the minutes of our previous public board meeting held on the 30th of May 2023. Are there any points of accuracy in those minutes? No. Turning then to item 5.2, the minutes of a previous meeting held as an extraordinary meeting on the 22nd of June 2023. Are there any points or questions on those minutes? And then finally, the minutes of another previous meeting held on the 27th of June 2023, again as an extraordinary meeting to consider a specific item of business. Are there any questions or points anyone wants to raise on those minutes? Thank you. We have an action log then under item 6. Is there anything anyone wants to pick up as a follow-through on any of those actions or ask any questions of the executive? No. Thank you. Then finally, in this sequence of matters, are there any matters arising from our last public board meeting held on the 30th of May 2023, which aren't otherwise covered on the agenda? Thank you. Well, those are the formal follow-up points that we need to go through. And we're now going to turn to our first substantive item, item 8, which is the Chief Executive's report. You have an enclosure, but Sam Allen, our Chief Executive, is going to highlight the main points in her report.
Thank you, Chair. Good morning, everybody. So today at our meeting, we will receive the independent report that Dame Marianne Griffiths has undertaken into the North East Ambulance Service. And I, as Chief Executive, wanted, alongside Dame Marianne, to express our thanks, my thanks to the families who participated in that independent review, and for sharing their experiences and giving their time. And again, our heartfelt condolences for the loss and pain they have endured since losing their loved ones, under what I know that all of us would consider to be very, very difficult circumstances. This is a detailed report, and as such, we are considering this in its own right as it's as an agenda item today. And later on this morning, we're going to be joined by the Chief Executive of the North East Ambulance Service, Helen Ray, and the Chair of the North East Ambulance Service, Peter Strachan. And both Helen and Peter will be presenting to us as an integrated care board how they as an organisation have responded to all of the recommendations that Dame Marianne Griffiths wrote in her report. What I would say, and I think it's important to note, as the Integrated Care Board, we do have a responsibility to commission these services, and in commissioning the services we have a responsibility both to ensure that the quality of the service meets the standards that we would expect, and also that the service is taking those actions seriously and in terms of accountability for delivery of those. You will have also seen in that report there are 2 recommendations that pertain to our role as an integrated care board, both in terms of the commissioning and oversight, contracting of those services, and also the investment made in those services. So as part of that item, we will also be providing an update on the assurance that we have for both of those recommendations. And Dame Marianne Griffiths did also make the recommendation that there should be an independent board with oversight of delivery of those recommendations. And as the Integrated Care Board, we've been working closely with NHS England as our regulator, who have been identifying the appointment of the individual who will chair that board. We're not able to announce that today because that has as yet not been confirmed, but we will certainly be sharing that news once the chair has been announced. And I would fully expect the minutes of that board to be made fully available. So in terms of the delivery of the actions, that we maintain that transparency and openness with our community, which is incredibly important, particularly in terms of the public's confidence in their provider of ambulance services. You'll also know that we serve the population of North Cumbria, and the North Cumbria population is served by the North West Ambulance Service. Whilst they aren't joining us today, I have spoken to their Deputy Chief Executive in their Chief Executive's absence and can confirm, as you would expect, as another provider of ambulance services, they're taking that report seriously. They are reviewing the report in terms of their own practice, and whilst there haven't been any issues identified, we will be asking them to provide assurance through our place committee in North Cumbria, which they've fully supported and signed up to. So more on that item when we get to it later on in our agenda today. In terms of the industrial action, there is no end in sight at the moment for this. I think, like all people involved in the delivery of healthcare, but perhaps most importantly for our communities, we are clearly hoping that the end will be in sight. We have just gone through the longest period of industrial action in NHS history. This involved a further 5 days of strikes by our doctors between the 13th and 18th of July, and our consultants, who are most senior medical staff, between the 20th and the 22nd of July. I do want to apologise for the impact on patients, but I also do want to thank all of our colleagues across the NHS and also the wider health and care system, our colleagues in general practice, our voluntary and community sector organisations, and indeed our patients themselves and our workforce, who have continued to do everything they can to minimise, where possible, the disruption on patients. However, we do know that there has been an impact, and where we've seen the impact has been in the cancellation of planned what we call elective care and diagnostics. And I think anybody who is faced with that situation, having either planned treatment and care postponed, it's not an ideal situation. And therefore we're hoping that these industrial action can be drawn to a close in the future. However, as we all know, this is a matter for government to resolve. So what we have been doing is making sure that where we can, we're minimising that disruption. Our colleagues who work in our emergency planning systems, our operational management systems, have worked incredibly hard. And I think to give some insight, during those periods of industrial action, not only do people put in additional hours in the days and weeks leading up to it in order to safeguard services, staff also work continuously 24/7 during that period, making sure that we are providing safe services. So I do want to commend our staff who continue to do that during these difficult circumstances. Of course, we are in the summer months too, it would be fair to say. So this isn't, whilst services, and you'll see when we get onto integrated performance report, there has certainly been no let up in demand for services. The months ahead, certainly if the industrial action continues, we do predict to be certainly harder. And these are the times when we know that our bed occupancy in hospitals will increase. We also see increases in attendance through our emergency departments too. In light of that, Chair, I do just want to talk about our focus on the winter plan. You'll see in the report, we've covered here the work that has been ongoing. So again, I sort of say winter comes once a year. It's one of our 4 seasons, but certainly in healthcare, it's here all year for us. So we're either planning, we're learning, we're adjusting, and we're preparing. This is also one of government's 4 priorities, and the recovery plan for urgent and emergency care continues. Our own urgent and emergency care network, chaired by Medical Director Dr Neil O'Brien, has identified 3 priority areas we're working on this year. We want to really make sure we're getting it right for people so that they're able to access services, that we're really focused on how we're supporting people to move through services, what sometimes unhelpfully, I think, for a patient perspective, referred to as flow. But it's really important that all of our services can work smoothly, and that where people do require a stay in hospital, that is as short as possible, and that we're really focused on transfers of care and getting people home. We've also worked with all our partners on a multi-agency escalation framework, and we're very focused around reducing unwarranted variation. As a provider of health and care services across the North East and North Cumbria, and you'll see in our integrated performance report, we still do see unwarranted variation, particularly in key metrics, and the 4-hour wait in A&E is one of those. So whilst we on average, if you aggregate our performance of our providers across the North East and North Cumbria, do favour well in comparison to other areas in England, we still do have unwarranted variation. And just recently, that could be, for example, one provider who is seeing everybody, perhaps 65% of people within 4 hours who arrive at an emergency department, compared to another who's seeing 90%. What we're really focused on is working with all of our providers to improve how they're all performing there. So that real focus on unwarranted variation. The NHS Workforce Plan, this has been big news. It's been well trailed in the media. It's the first time in the NHS history we've had a long-term workforce plan, and that was published on the 30th of June, along with a commitment of £2.4 billion of additional funding, particularly focused across 3 areas: training staff, with a particular emphasis on increasing apprenticeships and the number of apprenticeships available, and also expanding the apprenticeships available, particularly looking at, for example, medical apprenticeships. A real focus on how we can retain our staff at the moment, but also how we can make change and improvements into the working environment, whether that's training, whether that's education, but also the use of digital, so how we can really free up clinical time in order that our clinicians can focus more of their time on direct clinical care and less perhaps dealing with some of the clunky systems that still exist. I think also for us, this is an opportunity across a large system for greater collaboration. I was very pleased our provider collaborative earlier this year agreed a passport approach which enables flexibility of NHS staff to move more seamlessly across NHS organisations. That's a very good example of how we can get greater collaboration for the benefit of patients and using our workforce more flexibly and more wisely. So it's good news on the workforce plan. The hard work is how do we implement this? And I was delighted just several weeks ago to attend an event in this very room where David, who leads our workforce on behalf of the Integrated Care Board, had convened the whole of the health and care system through our workforce group, chaired by the Chief Executive of Newcastle City Council, Pam Smith, to look at our own workforce plan for the Integrated Care Board. And that plan has now been drafted. It does speak to and cover all of the areas in the NHS workforce plan, and that's out for consultation at the moment. We're looking to approve that through our newly developed system leadership group in September, and we'll be able to provide a more detailed update at our next Integrated Care Board on that. And then just finally, a couple of other areas would just like to mention, Chair. First of all, we've had the third of our strategic integrated care partnership meetings. You'll know that through that meeting we have approved our integrated care strategy. At the recent meeting we received updates from all of the 4 area integrated care partnership chairs who were all elected members. They covered a variety of areas and the focus of their work at the area level, particularly on population health. The integrated care strategy is one thing, having a plan where we've got very clear outcomes. The hard work is actually how we deliver that. And we do have the NHS part of that, which is called our Joint Forward Plan, out for comment at the moment. And again, we'll be approving that through our next board meeting. That plan is available on our website. It's available to all, and we're very much looking for feedback on that from all parts of our integrated care system. We do want that plan to be able to describe very succinctly how we're going to enable and deliver the NHS part of that plan, and very much working with our partners within the integrated care system. I touched in my report also, Chair, on our Waiting Well project, and Dr Neil O'Brien, our Medical Director, may well want to say a bit more about this. Delighted that through our Waiting Well programme we've been able to support 161 people who are waiting for elective surgery to prepare for that surgery, either physically, psychologically or both. And we're getting excellent feedback on the support, the changes people are able to make to enable a more successful outcome and experience for them in surgery. And that programme of work at the moment is subject to evaluation. My report also touches on the second special educational needs and disability assessment that's been undertaken across the Integrated Care Board. These are undertaken in local authority areas, the most recent one in Gateshead, the first one in Hartlepool, and my report touches on the findings of the Gateshead review that's been undertaken and the actions that will be delivered in place. And then just finally, Chair, I do just want to talk a bit about the ICB development. So we have just turned 1, so we've just had the first year of the ICB. You'll recall that when we were formed back in July 2022, we were formed from 8 organisations, 8 clinical commissioning groups that existed across the North East, North Cumbria, 8 organisations, each with their own ways of doing things, with their own culture, with their own workforce. Through our first year, we have made a number of changes, obviously, to set up the Integrated Care Board. We're now undertaking quite a significant programme, one we've called ICB 2.0, and not least because we would have to do this. When you bring together 8 organisations, the change happens incrementally, and one of the things that we have found is particularly trying to look at where the strengths were in each of those parts of the health and care system, what we want to do well once, how we want to streamline processes, so how we create a new culture for the organisation. And inevitably this has an impact on our workforce. We employ just over 700 staff working in our Integrated Care Board. In our first year we've also had 29 redundancies as a result of the changes that we've had, and probably what could be described as a slight curveball, something that was unexpected, but has been set by government as a requirement of all integrated care boards now, is that we make a 30% cut in our running costs. So reducing our overhead effectively by 30%. So for us as an integrated care board, that's quite a significant amount of resource that we need to take out. We've engaged our staff in our approach to this. We've met with over 300 of our staff now as part of the engagement. We're into an approach at the moment looking at actually how we will design the infrastructure, the operational model for delivery of the Integrated Care Board to deliver on our key purposes that you'll be familiar with as an Integrated Care Board, but most of all to deliver our core aim as an Integrated Care Board, which is how we use our resources wisely to the benefit of our population and delivering on our integrated care strategy. We do anticipate this is going to have change for people working in the Integrated Care Board, and I do anticipate, Chair, that we will be undertaking a consultation with our staff that's likely to be implemented in late September, early October. So this will be quite a significant change early on in our second year as an Integrated Care Board. As I said, all Integrated Care Boards are facing this change. It is a really good opportunity for us to really make sure that we're using our resources to deliver on our Integrated Care strategy, which of course we didn't have at the start of our Integrated Care Board back in July, but we do have that now. But I think, Chair, I know that we've kept the board well appraised of our approach to this, but navigating this period, particularly during a time when we have winter on the horizon. We've just recently taken on delegated responsibility for primary care, optometry and dental, which we're considering today. It's quite a significant additional requirement on the ICB in our first year, which is why we put a very structured and resource programme in place to enable us to deliver this. But important that we keep the board up to speed with that. Happy to take any questions, Chair.
Thank you, Sam. Questions and comments then. We will reserve discussion on the independent investigation report until it comes on the agenda later. But other aspects of the report that Sam's given us. Maybe I could start, Sam, with on the workforce matter. It's obviously a very important development. And when I was Chief Medical Officer, I presided over 2 rounds of bids for new medical schools. And this is clearly a big part of the workforce strategy, including the parallel with nurse education. And the 2 striking things about the previous experience of expanding medical schools was that it seems to increase quality and standards of care, having a teaching centre in a hospital that previously didn't have one. And secondly, it tends to be good for retaining staff in the region and in the area concerned. So I think it's likely that some of our universities that currently don't teach medical students, except those that are outposted from Newcastle, will be making bids. And it would be interesting to get early knowledge of what's happening there. So, excuse me, we're able to provide support where necessary. But on my discussions with the universities over the last year, I've been very impressed with the breadth and depth of education, nurse education, medical education, and some other health professionals that's being carried out right throughout the Northeast. Cumbria now exploring the possibility of a medical school. So I just wondered if you or David had any thoughts about that, or indeed Neil.
Yeah, thank you, Liam. I'll start and David can pick up. I think we're incredibly fortunate, as you say, here in the North East. We've got some wonderful academic institutions, Newcastle, Northumbria, Sunderland, The new medical school in Carlisle is happening and is well on its way to delivery. That's a partnership with Imperial in London. I think the real opportunity we've got is down on Teesside. So we have our two hospital trusts there working very well together in a new collaboration and partnership. Between them, they'll employ over 15,000 staff, and they have a very vibrant university, Teesside, which actually has a very strong track record, particularly in nurse education, who have certainly expressed an interest in this area, and we've got some very early conversations happening with them. And David, I don't think you want to pick that up.
Yeah, thank you, Sam. Thank you, Liam. So I think we have got a real opportunity in the area to look at new schools, and I know, kind of speaking to Teesside, they're very keen. And I suppose the important thing is to look at where we've got gaps in the workforce. So the big gap at the moment is in primary care, and what we do around kind of supporting primary care as well as dentistry. So I think they're two our big issues. But obviously we've got a bit of a lead-in time in terms of the dates when the workforce plan is due to be fruition. So it's a 15-year plan, and we do need to look at kind of how we manage that. So there's a big shift next year for 2025 in terms of increasing the places. Big thing for us is to look at how we support placement capacity and how we do that effectively across.
Yeah, that's usually the constraint. Isn't usually on the university placement. It's on the health service placement. Yeah, Neil.
Yes, thanks. So we are in active discussions with the existing medical schools and those that are aspiring to maybe offer medical places. We've been involved with Cumbria, work very closely with the postgraduate dean, Namita Kumar. We are establishing a strategic medical workforce group, which will specifically look at any issues relating from training right the way through to specialty training in the North East and North Cumbria, so that we can actively plan for what kind of doctors we may need in the future, depending on our health profile. So that work is starting. We'll have our first meeting in September. On the apprenticeships as well, that's the other thing I've been in discussions with UCLAN, which is it's a Lancashire one. I can't remember what the UCLAN stands for, but they're looking to establish a medical apprenticeship scheme. So I'm working with them, but it's still very much in the early days.
A quick supplementary before others come in. I mean, there's been a lot of talk over the years about orientating medical curricula towards primary care, or even producing primary care doctors only, and nobody's quite made that leap, I think, because of uncertainty about the way that medical practice and clinical specialties will develop. But I just wondered if there'd been any thinking about orientating future curricula more towards primary care.
It's my impression that the long-established medical schools have now incorporated a lot more primary care training in their undergraduate curriculum. And I've certainly observed that locally. The new medical school, particularly in Sunderland, the curriculum is focused more around training doctors in primary care and in psychiatry, which are chronically underserved areas. So that their curriculum is targeted towards that. Whether or not they will be successful in getting more individuals into primary care than, say, another university, it's too early to say to say that. But they are attempting to do that in Sunderland.
Thank you. Hannah.
Thank you. Just a couple of comments, if I may. So the first, obviously, it's great to hear that there are discussions ongoing about expanding the offer for medical schools in the area. However, obviously Durham did do this a few years ago, and for, I think, political and long-standing historical reasons, that partnership that they offered with Newcastle was quite tricky because of the rules around where medical schools can be placed in the region. So I guess one of my questions was around whether or not that will impact any of these potential plans, or whether actually geographically that issue is only between Durham and Newcastle. So I'll pause there and then I'll come to that.
Well, Sam can want to come in on this, but my experience of the two previous tranches when I was presiding over the national bids, there were there was a tendency for universities that had never had any medical education, even at postgraduate level, to look for an experienced partner. And in some cases, it was more of a mentoring relationship where the university was freestanding once it was established as a medical school. There were others that went into formal partnerships. Hull and York, Plymouth and Exeter were called the Peninsula Medical School, and Durham and Newcastle obviously was another one. Some of them over time separated again, and some remained unified. So I think there's different ways of doing it, but there's no doubt that there is a benefit to at least the mentoring relationship in a university that's never had any medical education before. I'm sure there are some parallels with nurse education as well, David. But Mike.
Did you have another point, Anna?
I did, and I didn't know if Sam wanted to come back on.
Just briefly to say, I think the experience of that is well known, and the learning from it would certainly be drawn upon in terms of any further expansions. Hannah.
Thank you. And just on that same point, I think there's also a great benefit to having medical schools placed away from Newcastle, because although I work at Durham University, the proximity between Durham and Newcastle, is very close. And actually, it would be great to see some of this expand further into the region, particularly down into Teesside. My second comment was just to flag that we've talked about the educational offer for medics primarily, but actually with dentists, there's also a huge gap. Again, they have to go to Newcastle or another city outside of the region in order to get their training. And my understanding is that makes recruitment and retention quite difficult. So would just say that dentistry is an important element to this as well.
Okay, thank you, Mike.
I myself was a graduate of Newcastle, having done my first 2 years undergraduate in Durham, officially Durham, though on Teesside. And a lot of my colleagues, are now doctors, remained in Teesside from that experience. It's really welcome to hear Teesside are potentially going to obtain a medical school at some point. My question is just to reiterate Liam's point really around placement. Our practice are repeatedly receiving requests from the local universities and also the deanery for placement of medical students and registrars, and we really struggle in terms of estate capacity, but also the amount of staff supervision time that's required. And I do think that this is definitely one of the high risk areas of the workforce plan. Have we had any sort of initial thoughts as to how we might address that as an ICB?
Neil.
So yes, this is exactly the kind of point that we need to pick up with our strategic medical workforce plan. It's all very well and good opening new medical schools, but if there are not the facilities out there to train the doctors, either in undergraduate or in local specialty programmes, then it requires planning and will require some structured investment in both time and infrastructure. So we will be picking that up. We can bring further updates to board once that group's established.
John.
Sadly, my question's not as strategic or as innovative as being asked about the university. Separate question if we finish that topic, if that's okay. Yeah. I saw the item about system leadership group on your report, Sam. I'm just interested in who those people are and where it fits in within our structure.
Yeah, thank you, John. So when I arrived in the system last year, we had a sort of a scenario, I think, post-COVID, where really fantastic system working, where leaders across health, social care, voluntary sector were coming together on a regular basis, united, obviously, in the response to COVID. And then, given that we're sort of quite a large region and an integrated care system, there was an absence of a forum that brought together leaders from across health, local government and voluntary sector, primary care together. So the system leadership group was supported by our joint management executive that Sir Liam chairs, which has overseen the setup of the integrated care system. And the membership comprises of representatives from chief executives in local authorities across the North East, North Cumbria, from our NHS Foundation trusts, from our primary care collaborative and wider system partners. For example, Dr. Namita Kumar, who Neil mentioned, who's our postgraduate dean, particularly given there's a whole piece of work around workforce, is a member. So it's quite a sort of multi-professional organisational group. So we meet for the first time tomorrow. All of the members of that group have been involved in co-producing how we will function as a group, and we've also had Sir David Pearson with us alongside us, helping to facilitate this. So I think one of the things our Joint Management Executive committed to do was to get this set up. And I think the value will be demonstrated over the next few months in terms of how that group evolves. I think we're not wedded to bureaucratic structures and meeting for the sake of meetings, but the system workforce plan is a really good example of one of the small number of items we need a forum like that to consider. It can't be seen simply as an NHS plan or a local government plan. It needs to be very much seen as an integrated care system working with all of our partners. So I'll certainly, through my report to the Integrated Care Board, keep that up to date. But that group has got a line here into our Integrated Care Board for governance purposes, but also into our Integrated Care Partnership, which you'll know is our joint committee with our 13 local authorities.
Graham.
Thank you, Chairman. If I could just go back to Sam's update on workforce plan. Sam referred to the use of technology. There is clearly a challenge with the dependency on technology as we go forward, and likely to be produced in the autumn will be a supplementary plan to look at the data, digital and technology workforce, how we can attract and retain. So there's a major push there. But in addition, linking to the collaboration that we have with a number of our universities, the Integrated Care Board is supporting a number of funding bids to develop new resources and skills in artificial intelligence and machine learning that will be used in a health and care setting. So lots of positive news there. Thank you.
I do believe there is, Lisa, but I'm happy to pick that up with you after the meeting.
Okay, thank you.
Just before we move on, David, you come in a second. I was just going to say, I'm wondering if our version of the workforce plan, which we'll obviously have to now develop with the national framework coming out, has got any specific initiative targeted at our most disadvantaged communities. Now, the reason I mention that is, I think I've mentioned before, some of the advisory work I do with the World Health Organization. In some of the poorest parts of the world, women living in local communities have become involved as community workers in a very transformational way with no previous experience. They've come in and helped to solve some of the difficult problems of vaccination, maternal and child health and so on, and rapidly become quite skilled. And many of the communities concerned are not well connected to any of the formal systems of healthcare, even if they exist, which they often don't. But I just thinking about our situation. I know that some of these initiatives will already be happening in our places, but given that we've had separate places, I'm just wondering if any coordinated action might be thought about in that area.
Yes, I think the big part of the plan, I think, is one of the things is around reform and how we do things very differently to what we've done previously. So I think we've got lots of opportunity in terms of new roles and how they need to work. And some of that is around generic working and how we encourage people kind of from those most deprived areas to how we do something very differently. So I think that's part of the plan, Liam, so we'll definitely put that in.
David.
Thank you very much, Chair. I'd like to ask a question about the winter plan preparation. I know it's only the summer, but winter comes every year. My recollection is that every year, or just about every year, resources are often allocated by the NHS England arguably too late to use the resources efficiently and effectively. And the question is, do we think that's likely to happen again? Is there a good chance of that happening again? And if that is likely to happen again, what's our plan to cope with preparing a robust plan when there is this question mark about whether there'll be additional resources towards the end of the year or not?
Yeah, I'll try and answer that, David. You're right that quite often we receive money. Sometimes very targeted and sometimes very general. It can vary from year to year. A few years ago, NHS were very clear that they'd put all the money out to either CCGs or FTs at the time. The money was there. Since then, we've seen, as last year, some additional funding come in, sometimes really, really late. So if I was a betting man, I would expect there to be additional resources. Yeah. And I think it's about working with the Winter Group in terms of, if the money comes in, how best to deploy it.
Sam, would you like to add on that?
Yeah, I think certainly NHS England have taken on board a lot of feedback on this, David, and with urgent emergency care being one of the 4 recovery priorities, particularly of government, we're in fact attending a webinar tomorrow hosted by the Chief Executive of the NHS and Sarah J. Marsh, who leads on urgent and emergency care. Just last week, there was additional funding made available to the ambulance sector, £13 million nationally, and our North East Ambulance Service and North West Ambulance Services are bidding against that, and that's very targeted to support the ambulance service to improve CAT 2 response times. So that's already one tranche of money that's come out. Most of the funding, it has been given to us as part of our operational planning process. Right. The other pot of money, which we're anticipating correspondence on over the next few days, is additional money into social care, several £100 million hopefully available nationally, and how that be made available to social care. And we'll work closely with social care over the weeks ahead on that particular point. So I do think the national team have taken on board the ask, which is please get any additional targeted funding out as soon as possible to support delivery of the very key priorities we've got through our winter plan. And you'll know those are around response times for the ambulance service. They're also response times in ED departments, and also very targeted resources to support discharge and preventing admission to hospital.
Thank you. Eileen.
Thank you very much.
Apologies to Chris Cross. Back to the idea of having new medical schools, particularly in places where need is. We need more practitioners, but we also need to think about new ways of working. And I think it draws a couple of points together. I think it is well known that as we train new medics and other healthcare practitioners, actually providing opportunities for exposure to research leads to better outcomes for people and for patients. So it's not just participating in studies, it's actually using evidence to shape new ways of working and to stop using practices that might be outdated and now are inefficient. So it's just a point as we think about that expansion of medical schools, training, having placements for training, we need to also make sure that we can provide opportunities to engage in research and to be appraisers and users of evidence so that we can shape care for the challenges of today rather than the challenges of yesteryear.
Okay. I don't see any other comments or questions. Yes, Sam, you want to concluding remarks?
Yes, thank you, Chair. Just a couple of concluding remarks. I just wanted to briefly go back to the issue Mike raised about primary care estates, just to say that this is an issue that is also being raised nationally, and I think there is recognition that to deliver both the primary care recovery plan and access targets, and also certainly the workforce plan, there is going to need to be additional capital investment into primary care estates, which are already creaking at the seams, particularly with the expansion of roles in primary care. So we're enhancing that workforce continuously. We are using digital to best effect, but there is a recognition by the Chief Finance Officer of the NHS for England that capital investment is going to be needed, and we would certainly concur with that from an integrated care board's perspective. I also just wanted to, in my report, and I do apologise, Chair, I didn't mention the awards that the ICB's won in its first year, and particularly Finance Team of the Year which do just want to recognise the huge amount of work of our finance team, but also our communications team, who won 3 awards in an industry national awards ceremony for our Bye Bye UTI campaign. And for me, that's also another really good example of working differently to enable people in our community, women, to access antibiotics through their pharmacy, as opposed to needing to go to their GP, their doctor's surgery. And I think, again, a bit like workforce and new ways of working, it is a good example of how we need to do things differently into the future in order to enable that access. And I just want to say congratulations to our communications team for that award-winning campaign.
Good. Well, thank you very much. And we move on now to our next item. As Sam mentioned in her report, one of the services which were previously managed by the regional office of NHS England is dentistry. And this is a subject where there is a huge amount of public concern about the lack of access to NHS dental services. So we've now taken responsibility for commissioning, development and oversight of this area of service, and we want to explore some of the early ideas how we might get to grips with the challenge. So passing on to Dave Gallagher, our area director, to give his early thoughts and those of his colleagues on how we might approach this new responsibility.
Okay, thank you, Chair. And mentioning colleagues, I have alongside me today, I've got Joseph Chandy, who people recognise as Director of Primary Care Transformation, and also with me Stuart Youngman, who comes across, is now one of our members of staff as part of the ICB, who's been instrumental in these early thoughts, and these are early thoughts in terms of how we tackle oral health with dentistry. So we've got a paper today that describes something we've supported from an executive point of view, but I want to just place that into context with a few slides, if I may. So I think
Just take the microphone a little bit closer, please, Dave. Thank you.
Yeah, is that better? Yeah, that's better. Yeah. So I think we all recognise, and if we don't, then we haven't been listening to the media, we haven't been listening to local people, some of the immense challenges that are around in terms of dentistry access. This says in North East and North Cumbria, it's actually nationally, it's regionally. Obviously, our focus is very, very locally. Part of the problem, and it's very complex, part of the problem is that dental services in recovering from the impact of COVID are really struggling. It was one of the services, because of the risk of transmitting COVID, that was really, really pared back through the pandemic, and it is really struggling to recover from that. We've talked about workforce in the last item. There are some significant challenges with recruitment, retention of dentists, and indeed the whole workforce model around dentistry and oral health. I think there's almost universal recognition that the National Dental Contract requires reform. I think it's recognised it's quite hard to get into, and that's a national issue that I think we know NHS England and Parliament are picking up, and that's something we need to work around as we do this. But the impact of all of that is in probably the bottom few bullet points there. Across North East North Cumbria, in 2020, the whole of 2020, there were 3 contracts that were handed back because practitioners were no longer able to service the NHS. In the first 5 months of this year, we've had 12 handed back already. So there's obviously a challenge there in terms of practitioners being able to manage the contract, manage the work for us. We've got 318 contracts for general dental services across North East North Cumbria. 20% of those are performing below 59%, and then that's because of some of the issues raised earlier on. All of this culminates in what we all know, and it's bad across the whole of the patch, and there are challenges there, but it's particularly bad in North and West Cumbria, North Northumberland, Darlington and parts of County Durham. So overall challenges, but some specific hotspots, challenge areas that we're looking at. And clearly this is something that we've inherited as an integrated care board. As colleagues are aware, from the 1st of April this year, this ICB, but now all ICBs have responsibility delegated from NHS England for dental contracting and commissioning. Good news is from the 1st of July, we have colleagues who've moved across into the ICB, Stuart is one of them. Pauline Fletcher, who leads on dental commissioning and is unable to be with us today because she's on leave, is another one. We've got some great knowledge and expertise that's moved across and experience. So we've got a bit of a running start on this, but nonetheless the challenges are huge. And with the best of intentions, the best will in the world, we're not going to break into this and solve the problems overnight. So I'm just managing all of our expectations as board as part of that. What we are doing though, and we've set up a task and finish group to look at some of the specific dentistry bit, and we're also setting up a dental commission to look at this in the wider sense, is to tackle this in 3 tranches. Not in series, but in parallel, so we'll start them all together, but there's some quick fixes, or the sticky plaster there, which is what this paper describes today, the immediate actions to stabilise services. In the medium term, we need to develop and will develop a more strategic approach to workforce service delivery and almost working around the dental contract as we have with general practice over the last few years. And fundamentally, and just as importantly, there's a piece of work that we need to do to develop an overall oral health strategy for North East North Cumbria, which again isn't built on a standing start. All of the local authorities have done work on this. Colleagues in NHS England have done work on this, but this is our opportunity to really pull this together so we can understand how local children, local people who have varying degrees of oral health have improved oral health to take some of the pressure off the dentistry services in keeping with our overall strategy for health improvement. So the paper that we've got today, which has been through the executive committee, looks at some really quick fixes that have come from working in the task and finish group that we've used Stuart's expertise and others' expertise on, to look at putting some non-recurrent investment in using slippage that we've got from the funds we've inherited from NHS England to do a number of things. A lot of the issues around dentistry and oral health that we hear in the media are around urgent access. So there's a piece of work that we've done to actually increase the dental clinical assessment capacity within the 111 service to make sure that people get the right advice, expertise and signposting for that. Linked with that, we're also increasing the out-of-hours treatment services that are available and extending the access arrangements that we've got. So by making better use of the funding that we've got where people are handing contracts back and there is slippage, to make sure we've got service for an additional 27,500 patient treatments for the rest of this year. These are very much non-recurrent arrangements and are predicated on actually the task and finish group getting to grips with what we need to do in a more sustained manner as we go forward. We've also agreed and support a local commissioning process so that we can actually manage quite slickly and quickly when contracts are handed back, how we redistribute the activity that's available in the contracts for other providers to make sure that we maintain as best we can coverage across the North East and North Cumbria. So that's a whistle-stop tour through where we are. Deliberately wanted to place that in the context of where we're at. The work on the Dental Commission Chair, as we build on that, we will bring back to board and we will be involving colleagues in actually putting some of that together. But for now, it was just to reassure people that we have the challenges, we know what the challenges are, we're dealing with them as best we can for now, while we develop a slightly longer-term plan to take some of the pressure off.
Thank you very much, Dave. Do your colleagues want to add anything to the... No. Okay. Right. Can I ask a very naive question? Has anyone ever proposed the idea of a second dental school for the region?
That's not something in our team that we deal with. Health Education England is the route that would go down. So in terms of a second dental school, I couldn't answer. From our perspective, what we would like to try to do whilst those larger scale reforms come through in terms of workforce and dentistry nationally is try to work with the local Health Education North East teams as were, and UCLAN in terms of North Cumbria where we've got the harshest of our workforce issues, to try and come up with joint initiatives. So there are discussions around things called Centres for Dental Development, which are in effect sort of local based services where we've got university training undertaken, foundation dentistry in terms of performers list entry undertaken and general access delivery all in partnership to try and develop local workforce arrangements. And in addition to that, through our procurements, try to develop foundation dentistry hubs, which isn't university schools as such, but it's trying to bring students into the NHS who are qualifying more readily, and also working on dental core trainee schemes whereby experienced dentists can develop their skills better by having a partnership approach. And we're looking to prototype and pilot one of those in North Cumbria currently, whereby Health Education England will offer a 2-day training development package, working with community dentistry services, and alongside that we'll run 3 days of access, so we get benefit on all sides. But in terms of the schools themselves, that's not something that sits within our portfolio.
And thank you, that's very helpful. Just before you speak, so do we know how many patients the Newcastle Dental School treats each year?
I don't. We don't contract with the dental school, so I wouldn't be able to tell you that.
Okay, thank you, Dave.
Probably just to add to that and linking it to the previous conversation we've had about medical schools, there's an opportunity to get into that and explore it to make sure that medical schools are developed, and indeed dental schools where necessary, to meet the demands that we've got locally. So it is part of the conversation we can have with them.
Okay, thank you. Neil, and then Eileen coming.
It's just to say I really welcome the report and that 3-phased approach. I think just to highlight, I think there's huge opportunities in the in further integration of health services, including dental, within a community networked infrastructure. If we think about some of the lessons we've learned from primary care, there is a nationally negotiated contract, but we as a local commissioning organisation actually commission a lot of local enhanced services from primary care to the benefit of our local population needs. Now that approach has not yet been taken in any great scale, as far as I can see, in dental. So I think there is opportunity and things that we can do to improve the experience for patients, and also in making every contact count in maybe some of the wider health priorities. So there's no reason why dentists couldn't start vaccinating people from seasonal vaccinations. So there's lots of different opportunities that we can look at that I'm sure we'll see come forward in that medium-term strategy.
Eileen, just before you come in, could I just say to Dave for you to just think about, you haven't really mentioned the constraints of the national dental contract, and that's something that's always raised in these discussions. So you might just give us a little potted history of that, or whatever. So Eileen.
Perhaps I was going to touch upon that. I remember in the not so distant past, if dental schools over-offered or over-recruited in terms of places for dental training, they were fined. And 1 or 2 individuals were given opportunities to have a gap year, if you over-recruited by 1 or 2 places. So there clearly is a role for national government to make sure that there is not that cap on dental school places, akin to what they've been doing, thinking about medical school expansion. And I'm not quite sure that that's fully in place yet. And then a more general point that I wanted to make was about prevention. I don't know where we are in fluoridisation, but we really do need to think, and you mentioned the directors of local authority colleagues who were working on this agenda, but actually obviously making sure that particularly with children and young people there's access to preventive education and opportunities to understand how to stop dental decay, etc. And then a very last point, I'm doing work at the moment on multiply deprived individuals with experience of homelessness, perhaps contact with the criminal justice system and substance use. And those multiply deprived individuals have got huge oral health problems. Having poor teeth causes great pain. That affects mental health. In terms of dealing with pain, and often substances are used in terms of trying to manage experience of oral health pain. So I really do commend the plan to have an oral health strategy and think about some of our more deprived and vulnerable members of society.
I'll let you just keep an eye on time, Dave. Maybe you pick up these different points whenever you sum up. And fluoridation, I was going to ask about where we are with that. David Stout.
Thanks very much, Chair. David, the non-recurrent initiatives totaling 2.9 million in the current year. Is it 2.9 million because that's all you have capacity-wise to set up during the remainder of the year, amounting to 2.9 million, Or could you have put more initiatives in place, but were constrained by the amount of funds available because you're relying upon slippage within the dental budget?
Okay, so just hold on to that, Hannah.
Thank you. My question was around what data we're collecting, both for the contracts that have been handed back. I know you touched briefly on that they couldn't service those contracts, but I wondered if there's any more detail about why in particular these were being handed back. And then separately but relatedly, what data are we collecting from existing NHS practitioners about their dental practitioners, about their current work, but also their plans for the future in terms of, I guess, predicting at this point how many more contracts we might lose? Thank you.
Claire.
Thank you, Chair. It's just in response to, Eileen, your comment around fluoridation. So there is some ongoing work with OHID, with the Department of Health and Social Care, and ourselves and the regional team too. It looks like the North East will be a pilot for this. There is some work and some funding being identified for a feasibility study linked to the operationalisation of fluoridation. And there is work ongoing also with the water company in the North East.
Thank you. Mike.
Just another point around data, really. So the focus on these short-term interventions, which I support, seem to be around urgent access, particularly, and managing that as best as possible. One of the big priorities that's been raised by Healthwatch at this forum in the past is the dental deserts, the areas where there's no access to a general dentist. And touching on Eileen's point about prevention, obviously we need those general dentists to be able to do checkups and prevent the need for the urgent access. So it'd be useful to have some data on that.
John.
Just trying to look at it from a member of the public's perspective, and particularly somebody who comes from one of the areas where it is particularly difficult, is the perception is, whether we like it or not, is the reason why dentists are handing in contracts is it's more lucrative to do private practice than it is to do public-facing NHS type work. And so there's a confidence issue with communities around this. So the question is, how do we, during the course of all of this, deal with that confidence and explain that it's probably a little bit more complex than just that lucrativeness, and put it in a way that we are doing something about it, as David and colleagues have outlined, but actually B, try and make that a little bit more palatable for people rather than it just being about money, because that's what people believe it is.
Okay, thank you. Dave, would you like to please respond to those points that have been raised?
Okay, thank you, Chair. Will do. And I'll probably ask Stuart to pick up some of the technicalities of this. But for starters, really, absolutely, there's a piece about comms that's part of this, and we're working with Claire's team to get the message out about, one, where we are with dentistry, two, where we're going, and the very important bit about the prevention piece that we've talked about, because that's the way we need to get into this, and that's working with schools and communities and the whole of the system. Claire's picked up the bit about fluoridation, but that would be very much part of the oral health strategy, so that's covered. The amount of money we're using, David, this is an initial, let's look at what we've got in the here and now to work with that. We're getting to grips with what our finances are regarding dentistry, and we've had conversations with David and the NHS England team being really clear what we have and haven't got in terms of the funding to do that. And as we get that much more clearer, which we're now getting to, we'll be able to come with a more comprehensive plan. But this was a quick start, to be fair. In terms of the contract, absolutely, I think I touched on it but didn't go into great detail. There's an absolute need nationally to tackle the contract, but I think, as Neil's described, we've got experience over the last 10 years of working around the general practice contract with things to supplement the contract while the work goes on nationally. But the contract is one of the reasons, and Stuart will probably enlarge on this, why there's a number of people handing the contracts back. While we've got some of the challenges we've got, and I think some of it then comes into the bit about, is it more lucrative to provide to the private sector rather than to the NHS? But I think, Stuart, you can give some more detail on the data particularly that we've got and that we're looking at.
Yeah, I'll try and pick up on 4 other points if I can. So starting with the reform.
I think you're going to have to come a bit closer, please.
Sorry. So picking up on 4 of the points if I can. Starting with the national reform. So If we're going to address the root cause issues around NHS dentistry, fundamentally it's the national reforms that will do that. Locally, across all of the country, the best we can do currently is look to put in risk mitigation actions, which is exactly what these are, whilst we await those reforms. Because we are constrained by regulation at the current time, not just dental regulation, but competition law and other regulation as well. So we can't step outside of those boundaries without compromising, obviously, the Care Board and others. However, we can stretch those boundaries and try to be innovative to address them. Just recently, a parliamentary committee that was independent looked at NHS dentistry nationally and published its findings in July, and I would recommend everybody have a look at those because it gives a very insightful, independent view of the current position of NHS dentistry, and not only that, suggests solutions. In terms of the history around the current regulations, they came into place in 2006, well before my time starting in the service. But from what I understand, historically they kicked off on a poor footing in terms of how they were set out, which created a number of key issues, which is why the dental workforce is disengaging to the level that it is, again, nationally across England. Those things are predominantly, it's a UDA-driven system. UDAs, for those who don't understand, UDAs is a payment, it's a mechanism of payment, in effect, for time. And in effect, that means that all NHS dental contractors are working to a targeted number of UDAs to deliver. And in order to do that, they've got to generate the patient throughput and the treatment in order to deliver those UDAs in any given year. Otherwise, they will have to pay back funding. So just to give you an example of that, if you had a contract of £100 for 100 UDAs, and at the end of the year you'd only delivered, if you were performing at 60%, you'd have to pay back for £40 at the end of that year, even though you've had that money paid in 12th instalments through the year to support the practice. So that creates huge cash flow issues for practices who can't manage that. So the profession are disengaged with the UDA system. Equally, the regulatory system is driven by UDAs, which are payment credits in effect, and time constrained, and therefore it detracts from the professional viewpoint in terms of the quality time needed to deliver the care and outcomes, because the most reliable patients are those who are generally regular healthcare seekers, if you like, looking for routine checkups, etc., as opposed to those who probably have the greatest oral health needs to be addressed, who take more time, more complex, and the regulatory system doesn't really fit with that. In addition, it's a demand-led system. It's not like general practice, which is registration, so they don't have a population to service. It's demand-led. You are only registered with a practice, for want of a better term, during an active course of treatment. So when you go into the practice, sit in the chair, have the examination, you're told what's needed, that treatment's undertaken, you pay for your treatment and you leave, and that's you now no longer part of that regulatory NHS system at that point. So there is a difference, and again, that doesn't work well necessarily for local populations as well as it could do, or oral health outcomes. And then there's the financial aspect. So the UDAs have a value attached to them. My understanding is that when the current regulatory system was put in place, the way that UDA values were determined for practices varied from practice to practice, and what you've now got is an inequality in UDA value attached to practices. So you can have two practices working in the same area next door to each other with radically different contract values and UDA values associated. So those are the underpinning reasons why the reforms and step change reforms rather than incremental reforms are needed. And as I say, the parliamentary report, for those who want to look in more detail, clearly outlines all of those issues in detail. Picking up on the reasons for handback, primarily, again, based on what I've described there, they are disengagement with the regulatory system and contract holders and associate performers wanting to step away from the NHS as a result. Financial viability, for reasons we've mentioned, particularly being worsened as the workforce withdraws from the NHS dentistry world, and you can't get the workforce in, you can't therefore deliver your contract, therefore your clawback or your financial hit is harder. And workforce recruitment and retention is very difficult across young dentists wanting to come in because they see the private dentistry world as the preferred option currently. Experienced dentists that we currently have are tired and disenchanted and looking to retire earlier, and it's difficult again to bring in overseas dentists because at General Dental Council level and performers list level for the NHS there are lots of issues in terms of trying to get overseas dentists into the system quickly to support contract delivery. So there's a range of issues there, all impacting local practices as well as nationally. In terms of the data, the one thing about dentistry is data is collected nationally. So for every patient that's seen and treated, there's an FP17 form filled in, which has got a range of financial, clinical data set information. It's collected nationally, it's reported nationally, and we can gain access to that locally. In addition to that, we're engaging with local dental networks and local dental committees because we fully see, in terms of what Dave's put forward today, that we have to come up with any mitigation actions must be in partnership with the local dental profession.
Okay. Thank you very much. We're well over time now. It's important that we do have a full discussion, but I need to keep an eye on the other items on the agenda. But Joseph, you wanted to comment?
Yeah, I just wanted to reiterate what Stuart said, that there is a myth and a public perception that dentists are leaving in droves because they want to make more money from private work. Actually, there's many dentists who are passionate about NHS dentistry. Sadly, I had a dentist approach me last week formally to say that his bank have asked him to consider leaving NHS dentistry for private dentistry because of the constraints of the national contract mean that he doesn't have enough patient throughput or enough workforce to fulfil the UDA contract and is therefore facing significant clawbacks. So we're working with that dentist to try and mitigate some of those cash flow predicaments as described in Stuart's piece. So just to make it very real that you know, there are a lot of NHS dentists who are passionate about NHS dentistry, and it's the constraints we've described is forcing them into the private sector.
Okay. Sam wants to come in, but just a very quick answer to this because it's potentially a big question. How much freedom have we got as an ICB to use methods of employment funding which could be seen to be cutting across the national contract? So a sort of impossibility scale maybe. Is it possible? Is it not possible?
I think, Chair, it is actually possible. It's about working with the contract, but then doing things around as we've described. So I think that there are some really good examples. We've had some good conversations with the local deanery about other workforce models that we can look at. So I think while there's some huge challenges there, probably understatement of the year, there are some big opportunities there.
And another quick question, are there any NHS dentists working in primary care centres which are mainly medical GP dominated?
Again, the dental contract doesn't provide enough incentivisation for dentists to be co-located with general practice. General practice has always historically been incentivised in terms of their premises occupation. So many dentists who are approached about moving to new primary care premises with GPs often turn it down and would rather remain in their terraced premises where they know they've got no overhead liabilities.
Okay, thank you, Sam.
Yeah, thank you, Chair. Just 3 quick points. This is a huge item, NHS dentistry, and without running the risk of repeating things, we know this is one of the sort of public's main area of concerns, and it's certainly what fills my post bag the most in terms of concerns being raised through our members of parliament locally with regard to access. I just wanted to commend our NHS England colleagues who've recently transferred to the ICB. As we all know, we are now responsible for the commissioning of these services, and I think we have had a group of people who are incredibly committed, very capable, and have very quickly been able to put together this plan. And I think as Stuart's demonstrated today, hold an incredible amount of knowledge. And from our perspective, one area we'll need to assure ourselves on is that we do have both the capacity, skills and capabilities to do this. But I am hugely optimistic about that, given the staff group that have come across. One question we will need to ask though is, are we investing enough in this? And whilst I know, David, your question, how we've utilised slippage money within the budget, it may be that we need to prioritise some additional funding for this, given the challenge that we've got, which is a national challenge, and as Stuart has set out, is very succinctly summarised in the Health and Social Care Committee's own review of this. I just wanted to set, Chair, the context of this paper today, which has had a very kind of immediate focus on protecting and retaining. And the one area dentists have told us through our engagement with the local dentist committees has been, if you do one thing quickly, try and reduce the number of contracts that have been handed back or people reducing their capacity, and that has been the focus of this. But I think the conversation has demonstrated there are a whole raft of areas we need to get into, and I hope that when we have our report back to the board in October that we commissioned at our last meeting, where we're taking a good look at dentistry and oral health, coming out of that we'll have probably a 3 to 5 year plan for how we take this forward. But I'm sure, Chair, this will be something we as a board need to spend quite a bit more time on.
Okay, well, we'll return to progress at the next meeting, and I think for the foreseeable future to at all of our board meetings. So thank you very much indeed, Dave, and to your colleagues. We'll move on now to the integrated delivery report, which is Jacqueline Myers.
Thank you, Chair. So, as in previous meetings, I'll take the report as read, but just draw out some key points and changes since our last meeting. So, starting with the executive summary, which is page 53 of the board report, just to note some changes in terms of escalation and regulatory arrangements since our last board meeting. I've referred previously in the board to the tiering system that NHS England developed last year, which is a process whereby they look at the relative performance of trusts in NHS England in relation to elective targets, cancer, and more recently urgent emergency care. And for those trusts who have the less good performance, kind of the worst quartile of performance, they're put into tier 2, and then the worst 10% into tier 1, and that comes with it the need to develop a recovery plan and have some enhanced oversight and regulation. So a change since our last meeting is that the North Cumbria Integrated Care Trust, who were placed in Tier 2 for their cancer backlog in summer of 2022, have formally been moved out of that tiering process in recognition of the progress that they've made. So that leaves us with just one trust involved in any of the tiering process at all. That's Newcastle upon Tyne Hospitals, who remain in Tier 1 for their elective performance, and that relates to the fact that they weren't able, through the planning round, to provide a plan to eliminate over 65-week waits. And so that was an automatic placement in Tier 2. And as the board knows, because we discussed it previously, that relates largely to their complex spinal cases. Just quickly, in terms of other changes since we last met, in regard to CQC ratings, South Tees NHS Foundation Trust has received an overall rating of good following the inspection that took place earlier in the year. There are some must-do actions that have been identified, but overall some real positives in that report, and we were glad to receive that. It says on page 53 that the CQC also recently visited North East Ambulance Service and that we were awaiting the outcome of their visit to the urgent emergency care services, but in fact we've received that outcome and the rating has been shifted from inadequate to requires improvement. So noted some progress made and further progress needed. There's currently a national programme within the CQC of inspecting maternity services. We've had the outcome of the inspection of the Newcastle upon Tyne maternity services. They were rated as required improvement, and a number of actions have been identified there. The rest of our trusts which provide maternity services either have recently had or are about to have an inspection, and so we'll see the outcomes of those over the coming weeks and months. Finally, the British Pregnancy Advisory Service, the CQC, published a report in June looking at their well-led, going a bit cross-eyed here, forgive me, looking at there, and a number of must-do improvements have been identified for them, so they're working closely with an improvement director to address a comprehensive improvement plan. In terms of the NHS England oversight segmentation process, where trusts are rated between 1 and 4, depending on how they perform against an array of measurements, we've just seen one change there, and that's Newcastle upon Tyne hospitals who've moved from segment 1 to segment 2. And that again is related to some ongoing challenges in relation to elective recovery. So they're the key changes I wanted to draw out since we last met. And then I'm just going to look at a couple of the key areas of performance and again draw out some points of note. So thinking about urgent and emergency care, in her report our Chief Executive mentioned some of the work that we've been doing looking at the A&E 4-hour performance target. This year, a sort of interim standard of 76% has been set for that target, so a minimum of 76% of patients who attend accident emergency departments being seen and either treated or discharged within 4 hours. As a system, we've set a higher level of performance for that, overall 80.8% by March next year, so rising progressively over the year. During the month of May, we slightly missed our plan. We set a target of 77.7 and we achieved 77.1. The report says that position's worsening. That's on the basis of a statistical control chart that looks at performance over the last 8 months. In fact, I'm able to report in terms of more recent data, we've seen that stabilise and slightly improve. But as Sam mentioned in her report, we've started to do some deep dives into individual organisations to make sure that the overall performance against this target, when looked at across the whole of North East North Cumbria, doesn't mask some variation that needs attending to. And that's resulted in us agreeing an improvement plan with one of our trusts a couple of weeks ago that we're monitoring closely. In relation to the Category 2 ambulance response time target, and again, as we previously discussed, this is a key target that actually relates to about 60 to 70% of all the ambulance journeys that are undertaken. I'm pleased to say that we met our own plan during the month of May, so 33.9 minutes against a plan of 34. We don't want to rest on our laurels there though, because relatively that's not a particularly strong performance, whereas the North East Ambulance Service is strong in its performance in relation to the other categories. They're 7 out of 11 for this month in terms of their performance. We're currently developing a plan to improve that, again, as Sam referred to earlier. Some additional national money has been available focused on Category 2 performance, and both North East Ambulance Service and North West Ambulance Service have indicated to us that they're putting significant bids in against that. And in addition, there's quite significant work going on with the ambulance service as part of our urgent and emergency care transformation plan, looking at some of the things that we can do as a system to support them to achieve and sustain acceptable turnaround times for their ambulance journeys. So we're monitoring that closely as we go. Just turning then to the primary care and community, I just wanted to note a bit of good news in terms of our 2-hour urgent community response standard. So you can see there that in April we achieved 82.9% of those responses occurring within 2 hours, and that's in the context of increasing numbers of contacts being delivered, albeit that they're below the plan. So some good responsive work going on there, and the reason I wanted to note it is it chimes with the point that Sam drew out in her Chief Exec's report about the 3 areas of focus for our upcoming winter plan. So focus number 1 is to get patients the right care in the right place first time, and as part of that we're doing extensive work in each of our places looking at all of the services that are available to meet people's urgent and emergency care needs in the community and connecting those services to themselves. So there's some really good work going on there, an opportunity to do more. A nice example of that is some work that's going on in South Tyneside between the local authority and the community services, using technology that was acquired by the local authority to help community services better observe changes in people's needs and respond to them and target their resources more effectively. So I had a nice presentation of that last month, and we hope to see more of that collaboration going on, strengthening our urgent care responses in the community. I'll just briefly then, Chair, turn to elective care. Pretty positive picture here. We heard earlier that industrial action is having a negative impact on our elective care, and we can see that in terms of some of the very longest waits struggling to meet their targets. So it's a mixed picture in terms of April, and that picture has continued through May and our early indication of the position in June. So we're ahead of plan in terms of reducing over 52-week waits towards the target of eliminating them by March 25, and also ahead of our plan to reduce 65-week waits by the end of March. You can see the numbers there, so that's really positive because they're quite large-scale numbers. Less good news in terms of the progress to eliminate 78-week waits. You can see there 169 people waited over 78 weeks against a plan of 114 in April. Again, I'm pleased to say that has improved. We've seen about 50 further come down off that during May and June, but it is proving difficult in the context of some of the impact of the strike action. And again, with the 104-week waits, you can see there 20 rather than the plan of 13. Predominantly, the challenge here has been in Newcastle upon Tyne hospitals. I've referred previously that there's a small issue around corneal transplants, and that's mentioned in the report. But we did see an unexpected number of breaches for South Tees Hospital in April. And so, as you would expect, we've been in contact with them and agreed a recovery plan, and they have a plan to eliminate those over 78-week waits by the end of July. I know we're tight for time, Chair, so I'll just a couple of other areas I wanted to draw out. Just in relation to cancer, you can see there that we are slightly behind in terms of our reducing the 62-day backlog. This is proving pretty tricky, actually. They're quite small numbers, but we're doing some detailed work with the support of the Cancer Alliance to get underneath how we can improve performance here. So just three quick things I wanted to mention. We've now acquired some national expertise, and we're doing a review of the urology pathway involving all of our providers to look at how we make sure that pathway is more responsive and delivered in a more timely manner. I'm pleased to say some additional endoscopy capacity has come online this month, and one of the challenges we've got is in our lower gastrointestinal pathway, which relies heavily on endoscopy in its diagnostic phase. And then thirdly, one of our trusts who was off plan has again produced a recovery plan, and we've seen some progress in recent weeks. So I hope to provide better news in relation to the 62-day backlog in future meetings. Just two last points. There's a sheet on maternity with some additional metrics this month in the report. It's showing a fairly positive picture in terms of things being green, but in conversation with David, our chief nurse, we want to do a deeper dive into that again to look at what the variation is underneath the overall performance to make sure that it's not masking some unwarranted or concerning variation. So we'll bring that back to the next meeting. And then lastly, on page 74 of the report, obviously some concerning data in relation to mental health standards for adults. So we have a new acronym for the board this month, which is that what was previously referred to as IAPT, Improving Access for Psychological Therapies, is now called NHS Talking Therapies for Anxiety and Depression. You can see there real concern around the levels of activity here, so a long way behind plan. And again, this was mentioned briefly by the Chief Executive, but we've initiated some short-term actions. We've got a recruitment drive going on this month to try and get additional capacity into these services. But as part of our review of contracts, we're stepping back and having a look at the way that we commission these therapies across the piece to make sure that we're taking the opportunities to have as strong an array of contracts to support. It is quite a diverse field where it's not a case of a single contract, but we're looking at various contract mechanisms and approaches to try and increase the provision here. This is an area where we've had significant increases in demand in recent years, and we really are struggling to keep pace, so further updates on that in future meetings. And finally, just in relation to the number of out-of-area placements, again, you can see there that we're struggling to make progress again, and this was reported at the last board in relation to our plan. So just a couple of notes about the work that we're doing there. We're in the process of completely overhauling the way that we manage complex cases in the ICB to make sure that we've got real robust oversight of all of the individuals who are in receipt of complex packages of care, and there's a strong overlap between those individuals and the people who are in these out-of-area placements. We've also undertaken a review of providers, both in area and out of area, and we've just started some really significant work on a housing, health and care plan, which in time we hope will develop some real sustainable solutions around providing in-area homes for people who need complex packages of care and facilitate more sustainable arrangements for them. So that's a whistle-stop tour of the reports. Obviously, as ever, a complex and detailed report, but happy to take any questions, Chair. Thank you.
Thank you. Mike.
A couple of specific questions, if I may. So one area that I see in practice where, three areas even, where there's very long waiting lists aren't really encapsulated by this report. So referrals for diagnosis of autism or consideration of gender dysphoria or diagnosis of ADHD, the waiting lists for all of those frequently exceed a year. In the case of gender dysphoria, often exceed 3 years. But the current metrics that we use look more at physical health conditions rather than these mental health conditions. So I'd be grateful if we can get an idea of if we can incorporate that into the report so we can understand what the weights are for those and how we progress on it. And a separate question, do you want to answer that?
I'll do that one first.
Yeah.
Yeah, thanks, Mike. So in regard to those waiting times, certainly in relation to the first two around sort of, if you like, what we might refer to as neurodiverse diagnostic pathways, we've got a significant piece of work going on. One of the issues that we've struggled with is that there are no national metrics for the measurement of those waiting times, and so there's no definition. However, we have made significant progress. We're now receiving data from our two big mental health, learning disability and autism trusts, and we're in the process of garnering data also from our other FTs, because particularly for the 0 to 5 year old population, the diagnosis for these conditions is often done in the acute trust rather than the mental health, learning disabilities and autism trust. So we expect to have a report, I think it's to the next Finance, Performance and Investment Committee. It's something that we've been in discussion about. In fact, on page 48 of the report, it does refer to this work being ongoing. So we will be able to provide a report. And then in addition, in terms of the kind of actions and mitigations to address those long waiting times, Levi, I think, is bringing in a report in September looking at the priorities for the Mental Health, Learning Disabilities and Autism Transformation Plan. I have to come back to you on the waiting times in relation to gender dysphoria, because it's not something that we've yet had a look at specifically, but I can take that away and report back at a future meeting. Thanks.
Thank you very much, Jacqueline. That's really positive. A separate question. I note from Dame Marianne's report that we'll come on to later that one of the factors that they picked up on in the North East Ambulance Service was the low reporting rates of significant events. In this report, we get the total number of significant events reported by month within the North East and North Cumbria ICB. However, I don't know whether those numbers are high, low. It's hard to understand what they mean. I think given that we've had an example within the area of where low reporting rates are significant, it would be nice to get that in a format that we can digest.
So normally we picked this up at Quality and Safety Committee just last week, Mike. So normally in terms of incidents that are reported, we get between 11 and 36 a week. Incidents reported across. So that's our kind of, if we're on the SPC chart, that's kind of the numbers. So we can tell when there's variation from that, but we'll do some more work on that so we can see where it is more clearly.
Just as a general rule, the reporting of incidents across the world is way below the reality. And the only category which gets close to everything being reported is the never events category, which is supposedly a statutory thing where people shouldn't be failing to report. But the serious incidents come in between not just normal reporting, which is not over serious matters particularly, but it falls somewhere between that and the never events. So there will be a degree of underreporting, definitely, and we need to try and do something about that, because the opportunity for learning, as you imply, is lost.
Chair, if I may, I think it's a really important point, Mike, in terms of where we've got an average across the integrated care system that might be masking some really excellent performance in some of our providers and some real opportunities for improvement. And I think probably where we'd want to get to as an ideal is that we've got this report on our public website, and actually the public can very easily in 1 or 2 clicks see where we do have that variation. And I think through the improvement work that we do, working with our provider collaborative and across the system, we're able to really target and prioritise interventions. Now that is something the tiering system does. It's something we do pick up in our oversight meetings, working jointly with providers. But I do think we do need to be cautious when we're looking at some of this data in terms of what's an aggregate position, and where we're making sure that we're targeting our focus on not just the areas for improvement, but also celebrating and sharing the really excellent performance too.
Thank you, Sarah.
Thanks for your report, Jacqueline. My question was just looking at data and activity and understanding population movement. We're aware that obviously there's an international student community which is going to, be coming into our region throughout the next year. And whilst we obviously welcome the enrichment and diversity that this will bring, as well as a potential workforce for us, I was just trying to understand the impact that increasing population numbers will have on regions, and are we doing a piece of work around this?
Thanks, Sarah. So I think from a data point of view, perhaps I wouldn't be clear that we're doing a specific piece of work on it, but more operationally, where we become aware that we've got significant changes in populations, and that might be a result of placement of migrants, or as you describe, it might be a significant increase in bringing in international students by one of our academic institutions. We do have a kind of business continuity framework which we activate to respond to that, and we have a multi-agency approach through our local resilience fora to work together, and generally the response to a new population arriving within our patch, the response is led by the relevant local authority, but we lead the health response, and so we have some very specific things that we think about in relation to those populations, whether it's their vaccination coverage, whether there are particular, so with the young population we might particularly think about sort of sexual health type services and contraception type services. For the young children coming, then there'll be another range of services, and we have arrangements in place to register new populations rapidly with general practice, so that we can make sure that they've got access to healthcare from when they arrive.
So we've finished, I think, the discussion. We will look, Jacqueline, at the timing of this issue for future agenda items, because I think it is an important review that you do for us to know about performance comprehensively, and I think we're probably not allowing enough time for it, and look at possibly some other ways in which we can have a fuller discussion on what you're making. So thank you very much indeed. Over to David Chandler now for the finance report.
Thank you, Chair. I'm conscious of time, so I'll be brief in terms of going over the report, because I'm sure everybody has already read it. So I'll just focus on a few key points if that's okay. So this is the month 2 report, so it's very early in the financial year, and that will affect some of the financial figures that we're able to report. If I give you an example, prescribing data is always 2 months in arrears, so it's very difficult to report with accuracy in that area at this time of the year. But looking at a few key points, the ICS, we have a plan to achieve a financial deficit of £49 million. That's now been agreed by NHS England. We're on track to achieve that plan from a forecast outturn point of view. The report does show a deficit of £1.8 million at month 2. That's meeting the provider sector. It's in areas such as pay pressures, industrial action, unachievement of cost efficiency programs, and a Microsoft license issue that is popped up nationally. They are the risks around the achievement of that ICS plan, and I'll come to that in a second. The ICS position, we have a target to produce a planned surplus of £32 million, which is part of that deficit I talked about earlier. Again, we're on track to achieve, at month 2, that planned surplus, but we do have significant financial risk in areas like prescribing and packages of care being in excess of levels of funding that we have from NHS England to pay for those things. I mentioned financial risks. That's probably the main area, Chair, that I would bring to the board's attention. So you'll remember at the start of the year we talked about unmitigated risks of around £250 million. That's probably the largest level of financial risk that I can remember for a region of this size. The financial risk reporting sort of kicks in really from month 4, formally, in terms of how we pull that together. So what I'll look to do for the next board meeting is maybe to emphasise that in the report and just sort of bring it out more to the forefront and show that the board exactly where we stand in that position. But at this moment in time, the level of financial risk is similar to what we had at plan, as you'd expect, because it wasn't that long ago we had the plan submitted and approved, agreed. The capital side of things, you'll see a red flag on capital. Just a reminder, everybody, that's relatively normal this time of the year. We were encouraged to put a plan in that, if you like, overspends on capital, knowing fine well that by the end of the year, we'll bring that back into balance. That's a normal thing that most ICSs will do. Final few points, Chair, if I may. The paper includes a request or requirement from NHS England as part of our plan that we submitted around putting spending controls and other assurances in place. A copy of that letter is attached. This has been reviewed by directors of finance and chief executives. Those spending controls and processes have been agreed. Oversight and assurance on those controls will be via Director of Finance in Chief Executive Officer Leadership Forums and reporting into the Finance Performance Committee. We've also agreed that we'll do more formal reporting and assurance around ICS efficiencies as a whole. That was another requirement from NHS England. 2 final points. The month 3 position is now known, I know it's not in the report. The month 3 position is not materially different to the month 2 position. However, as we go through the year, financial risk is something that we need to be really concerned about. And lastly, the medium-term financial plan. We are now working collectively to produce a 5-year financial plan that is due for submission in its initial stage to NHS England at the end of September. Given timeframes, that will be a step in the process, I believe, in terms of a fully formed medium-term financial plan. And we will, of course, bring copies of that to the board for consideration. That's all from me, Chair, that's okay.
Thank you. Comments and questions? No. Well, thank you. I'd like to just propose a change to the agenda because I'm conscious that some people listening online may be particularly logging on to hear the independent investigation report discussion. So with your agreement, Neil, we'll have our break at the scheduled time, come back and consider the North East Ambulance Service independent investigation report and then come to your item. Okay, so we break now, and if you could please be back at 35 minutes past the hour, whichever hour it is, 11:35, I think. Well, we're resuming the North East and North Cumbria Integrated Care Board meeting on 25th of July 2023 after a short break. And we're coming now to the item that our Chief Executive, Sam Allen, flagged up in her report, the independent investigation report into the North East Ambulance Service. And we're joined for this item by Peter Strachan and Helen Ray, the Chair and the Chief Executive. So good morning to both of you. We're going to start with some opening remarks from Sam, and then David Purdew, our Executive Director of Nursing, is going to speak. And then I think Peter and Helen, you have a short presentation, and then we'll have some open it up to questions and discussion. So over to you, first of all, Sam.
Thank you, Chair. As I said earlier today, we're considering the independent report that's been undertaken by Dame Marianne Griffiths. And as you just commented, Chair, welcome the Chair and Chief Executive of the North East Ambulance Service with us today. I just wanted to start the item, obviously holding in mind the families who participated in the report, and again to express our thanks both to Dame Marianne Griffiths for the work that she has undertaken, and for all parties, including the North East Ambulance Service, for their full and open participation and cooperation in the process and throughout the process. I do again want to express our heartfelt condolences also to the families who have been affected by this, and obviously the loss and the pain that they've endured. And I think particularly given the fact that we've had such a detailed report, it is only right that we do take the time in public to both receive it, assure ourselves as the Integrated Care Board with responsibility for the commissioning and oversight of our ambulance services in the North East, working with the provider North East Ambulance Service, that these recommendations have and are being progressed, and also to ensure our cooperation as the Commissioner and the funder of these services in the actions that we also have relating to two of the recommendations. I did also just want to again comment that the North West Ambulance Service, who provides at the ambulance service for the population we're responsible in North Cumbria, has also confirmed to me that they're taking this report very seriously, that they, as with any report that's published nationally like this, will be looking at it carefully to ensure the lessons for them. And I think equally, as I'm sure when we get into discussion about the reports, this is a report where every NHS organisation should be reviewing in terms of the lessons. And I also do want to recognise the role of speaking up that has played a part in these issues being thoroughly investigated and the wider learning. And I'm also sure we'll also get into understanding how we can support whistleblowers too, who do speak up, and also people who use the freedom to speak up process that we have across all NHS organisations. So, Chair, that's all I wanted to say on the matter for now, as we hand over to the Chair, Peter Strachan, and Helen, who we welcome today, to address us in terms of the recommendations in the report and how they've acted on them and taken them forward.
Thank you very much, Sam. Thank you, Chair, and good afternoon, colleagues. Can I say, first of all, we welcome Dame Marianne's report. We've engaged, Sam, as you said, fully with the investigation, because we think that's a really important thing to do, to make sure that we learn from everything that's happened and that we are thoroughly transparent in all that we do. We accept that we have not got things right, and in doing so, we've caused significant distress and ongoing grief to those families that have been affected. We have apologised unreservedly to those families, and I'd like to reiterate that again this afternoon. Given that many of these matters happened some time ago, you would not be surprised to learn that we have been on with the job of making improvements. And that's been something that we have been getting on with and has been adopted by the whole board of the North East Ambulance Service. And you have my assurance this afternoon that the whole board is committed to making those improvements and embedding the improvements that we have made. In taking us through the detail of the recommendations and the assurance that hopefully we can give you this afternoon that we have indeed got on with it, I'm going to now pass to Helen Ray, our Chief Executive. Helen.
Thank you, Peter. Thank you, Chair and Sam, for that introduction.
Just before you proceed, Helen, the microphone needs to be a little bit closer, I think, just picking up the sound. Good.
Is that better? Thank you. So I just thought I'd give a little bit of background. I'm not planning to go through the slides line by line, and I know you've received copies in your packs. But I think it's important to note that that resulted from a discussion in Parliament in June 2022. So we are, a year later, and as Peter said, important that we've taken forward some of the actions within that. I think it was good to have an independent review appointment through Dame Marianne for undertaking that, and that commenced in September 22 last year. As Peter said, we wanted to fully engage with that and have obviously disclosed numerous reports and undertaken numerous interviews with Dame Marianne and her team during that time. I wanted to just note, and I'm sure all of you have as well, that there is some correlation with our CQC report, and we shouldn't lose sight of that and the work that has been undertaken since the CQC report was published in July. And just to note that in our most recent report, there was an acknowledgement from the CQC that we were on the right path and that some improvements had been made. And the report was published, as you're aware, on the 12th of July. I won't necessarily cover that because Peter has said that, but again, I think, it's important for us as an organisation to hold the families in our minds as we think about the recommendations and think about the lessons that we take. And we are hopeful that we'll be able to have an opportunity with those families to give them some further restorative justice throughout this process, something that they certainly deserve from us. So our view at this moment in time was that we were acting on many of the concerns that had been raised prior to the publication of the report. When I came into post in September 2019, one of those cases was quite live for us. Peter and I undertook to review that case personally because I could see that there were some issues in terms of our reporting processes and mechanisms to the coroner. So we root and branched reviewed one of those cases very early. And that is obviously included in that assurance statement to demonstrate that. We are working very closely with our regulators, not just through yourselves as integrated care system, but also the CQC and our colleagues in NHSE through our quality improvement group. And obviously aligned to the CQC, you'll be aware that we had a Regulation 29 notice that picked up some of the concerns actually that Marianne's report also picked up. And I'm pleased to say that in the latest review in July that has been lifted again, which that's demonstrating the work that we have taken forward. So our assurance statement is really clear. We are asked to meet with the families and formally apologise, and as Peter has said, we have been in contact with the families over that period of time, but we reiterate that apology and would welcome that opportunity to meet with them. I think Sam has already said that our colleagues in NHS England are working through what that independent oversight committee will look like, so that hopefully we can work with the families to give them a much deeper level of detail on the lessons that we've taken forward than perhaps is clear to them at this point in time through just the assurance statement or the press briefings. It's important that we have specialist support for the governance, and we had already started to work with an independent company value circle,
As we came out of COVID, actually, that was the work that we wanted to pick up. You know, during that period of time when we were lighter touch in our governance, we probably underestimated as an organisation what it was going to take to pick that back up again, and really round back to that high level of board assurance through our frameworks that we need to provide, both internally to our board and externally to our stakeholders, to the public and to our regulators. So that work is underway now, and it's part of our review of well-led, which will continue over the course of this year. And we anticipate a further review by the CQC potentially in 2024 of that work. But we need a little bit of time to embed those new governance processes in place. But a very clear governance framework now, which connects us through from what we are determined. Lots of people talk about ward to board. Of course, we don't have any wards, but what we do have is 53 individual stations and areas that we need to make sure we are connected to. So team to board is the work that we have underway at this moment in time. And, you know, it's in its infancy to some degree, but a significant piece of work to allow us to address those connectivities, especially to share the learning when things do go wrong in the organisations. That is just a continuation of that. So a comprehensive review of our incident processes was something else that was asked for, both in Marianne's report, but also in the CQC report. So we have further strengthened that, and we're grateful to David and his team, particularly for the support that they have given us within that, drawing on some of their expertise from other areas. It's always good to learn from others in these situations so that you can take the best practice forward. So we've already strengthened our serious incident processes. That has been shared with North East North Cumbria colleagues and our regulators in NHS England. Our next step will be to introduce the new patient safety, patient incident review framework by the end of 23-24, and the executive team have just approved the direction of travel for that and the posts that we will need to put in place to make sure that we have the right construct and the right capacity to allow us to take that forward. But again, we've done that in an open, transparent and shared way. The third recommendation is addressing the concerns that the reports were changed inappropriately, and to consider whether accountability arrangements for the organisation have been followed. This is a really important recommendation, I think, for us just to draw out with you today. So as Peter said at the onset, we absolutely acknowledge that our systems and processes were flawed at the time when we were dealing with the coroner and dealing with the families that are mentioned in this report. They've been very brave in connecting into this report, and they deserved better from us at the time, and we didn't do well. We have fully reviewed all of those systems and processes. When I picked that up early in my tenure, it was clear that those processes were disjointed. It was clear that there were too many tiers and too many people involved in ensuring that reports were disclosed, and therefore that resulted in a lack of timeliness and an ability for people to make the wrong judgment call on adjustments of a report. So you all know, and I know, that a coronial report, if it's taken forward by an investigating officer, should not be altered. If there is a disagreement, or if there are concerns about any element of that report, an addendum should be made. The report should not in any shape or form be changed. I think the team at that point in time did not have a really firm grasp on that. They needed to have education, support to allow them to understand what could and could not be done. We reviewed all of that. I have to say that personally, when I reviewed that, I didn't find any malice with the staff who were involved in that, but they clearly made grave errors. And we dealt with that with each individual in a just way, I think is how we would want to describe that. And we can obviously talk about that more if anyone has any questions. And we also conducted a review into a significant number of historic cases because we wanted to make sure that we had no further issues of concern for disclosure, particularly to the coroners. We reviewed over 400 cases at that point in time, and we found, in addition to the cases that are mentioned in Dame Marianne's report, that there were another 5 cases where full disclosure to the coroner of things like the appendices of reports or full reports had not been disclosed. We wrote to each of the coroners, and you'll be aware, because we represent the whole of the North East, we are dealing with a number of coronial officers. Our medical director at the time wrote to each of the coroners, disclosed those items that were missing, and gave them assurance that they'd had a complete bundle. The coroners were happy with that, and all of those disclosures were pre any inquest. I think that is important to note. So they were disclosed before anything had gone through the formal coronial process. So just wanted to reiterate that that was a root and branch review undertaken by the organisation, just to determine if there were any more concerns that we needed to address. So that came down to some of our training also. So one of the cases talks about that pass through from call handlers to our clinical advisory service. And I just want to be really clear that we audit that robustly. Our NHS 111 call handlers and our 999 call handlers are not clinical. And I think sometimes members of the public think they are dealing or speaking with a clinician when they make that call. But they do have backup from our clinical advisory teams, and we audit regularly all call handlers to make sure that if they have some changes that they could adapt or some lessons to learn when we're dealing with the algorithms, that is taken forward with them. And we audit that ourselves internally. So we audit the auditors, if that makes sense to everybody. The board was asked to seek assurance on the ongoing coherence and confidence of the Quality and Safety Directorate, given the painful experiences that they had suffered. And this is to do really with a recommendation that there was some disjointed behaviour and some behaviour that was really not representative of how we would expect our teams and a board and executive team to behave. So let's just be open and transparent about that. Those were reviewed and dealt with at the time. We had a number of people move into different organisations and move away from NIAS. And then we worked very closely with both our quality and safety team, but importantly as well, our coronial team, to make sure that the system processes from the commissioned work that Peter and myself asked for as the independent review through our non-executive director colleagues, that task to finish group picked up all of the areas of learning that we had from the reports that we had already published, commissioned at that time, and that the lessons were taken forward. And our Trust Improvement Group started in November 22 and is still in place now and reports through into our Quality Improvement Group, of which Sam and the team are members to hold us to account firmly in that frame. So we have a really different approach with our quality and safety team now, and I have a high level of confidence that they are well supported by the current team in place now, and we work very hard to listen to them. Sam touched on freedom to speak up, and that comes across in our presentation shortly. So the Oversight Committee, I think we've already touched on, and we would really welcome that opportunity and that independent chair, and we continue to work with our NHSE colleagues as we set that up, and we expect that to be a public accountability committee, and for those reports and those discussions to be made public, because it's not only for the assurance of the families who we are engaging with from the report, but also for all families in the North East who need to have a real high level of trust and confidence in us as an organisation. There is a senior doctor, so those of you who have worked in acute providers will know that the medical examiner model has been well embedded in hospital provision for a number of years now, but was never mandated for the ambulance service. One of the recommendations that Dame Marianne made after an independent medical examiner came and had a look at our processes was that we should pick that up as good practice. I think that is absolutely the right thing to do. It gives a really higher level of confidence in the reviews of deaths, particularly the learning from deaths reviews. So we are working with Northumbria Healthcare, who have significant experience in this. Northumbria are our buddy organisation as we move forward with our learning, and Jeremy Rushmer, their medical director, and Kat Noble, our medical director, are in discussion about how that might work and what learning we can take to make sure that our approach is the right approach. It won't be the same approach, I don't think, as acute provision, but there is a real opportunity for us to almost be the trailblazers in this and have a medical examiner model that can be used right across the ambulance sector, which I think will add some value. There needs to be a clear structure for information flows. So, as I said earlier, too many people involved, and a real difficulty I found in following the process in a linear way to make sure that only one team were dealing with the coroners, which is how it should be. We've addressed that now. Those changes are all underpinned by our data management system. We have undertaken 2 internal audits since Peter and I commissioned the review, and our latest audit report gave us better assurance. So we had a limited assurance report initially, but we now have a higher level assurance report, and it is part of our development work to further review that again this year. It is in our audit cycle for the year of 23-24. So again, not just accepting that that has happened, but actually monitoring and being able to provide the evidence that that change has been made. And that links into the statutory requirements and reporting for the coroners and claims team, so that the internal governance processes are explicitly separate. They have been separate for a significant period of time since 2021, but I do accept that when I picked up those cases early, they were not separate. They were definitely very confusing. But since 2021, I am confident that that is a single routine, and the coroners are very comfortable. We have continued to engage with our lead coroner locally and with all of our coroners to make sure that the reports and the way we process things for them is as they would expect, and we regularly review that with them. And in 10 and 11, the recommendations were for a revised process around the settlement agreements, which is already in place and goes through our nomination and remuneration committee. And also we are very clear, our non-executive director colleagues hold us very clearly to account for those recommendations for the Treasury guidance, which is obviously equally as important. So the process outlines the factors that the teams must consider. Our Director of People brings that forward to the non-executives and through Nomination and Remuneration Committee as is appropriate if any settlements are being considered. And we've had a specific question to provide assurance around settlement agreements prior to 2020. The Nomination and Remuneration Committee, when it next sits, will consider that, but I have to be honest and say that will be challenging for us because it will mean data mining every individual case of someone who has left the organisation. because the data collection prior to 2020, when we picked this up, was not robust. So we will consider that, but I think that is it will be quite a significant challenge for us. But of course, it is one of the recommendations that we will consider in detail when the Nomination and Remuneration Committee next sit. And then there was a piece about external support for the board overall. We are a relatively new board together. We are a very new executive team, and all of the executive team, including myself as chief executive, are in our first executive or first chief executive posts. That's not to say we don't bring a lot of experience with us into those posts, but it is a challenge to keep that cohesion and that unitary board approach, which obviously we want to have. And we are working on where we've started our board development programme. We had gone through a comprehensive board development programme just as I came into post over 2019-20. But then, of course, we lost a couple of years to that thing that we've forgotten about a little bit called COVID. But we have picked that up again this year and have a formal executive programme in place and a formal board development programme in place, both running concurrently. And we've also got support from our buddy, as I said, and then individual development for new board members, including coaching, those observation shifts which are important to connect with the front line and understand the service, and professional and sector-wide networks for peer review are important. So we are part, for example, of an association of ambulance chief executives which draws together the 10 English ambulance services and the devolved nations, so that we learn from each other. And you know, for this example, with the independent review, we take that into our ACE forum for the learning to be shared with colleagues. And then we touched on freedom to speak up arrangements. And one of the things that we were already part of was the review that was undertaken by Jane, I always get her name wrong, Chidgey Clark, I think is the correct pronunciation. So we were already working with Jane and the team in her offices to look at the processes for ambulance trusts for freedom to speak up, which can be challenging given the dispersed 3,500 square miles that we cover for our staff. But we made a decision to invest in further capacity for our freedom to speak up. So we have trebled that capacity over the last 6 to 8 months, and we are starting to see that the benefit of that actually with our teams, because our guardians are able to spend more time out and about talking to colleagues face to face, and I think that has been extremely helpful. And our plans around the freedom to speak up were peer reviewed by NHS England in November 22 and supported as being appropriate level in relation to the scope and capacity and the independence of our guardians. And we'll continue to work on that and are rolling out our ambassadors. That will take a little while because we want them to have plenty of support and plenty of training. But by 2024, we will have that network of ambassadors also in place. And we took that learning from some of our colleagues actually in the Northwest who have implemented that very successfully. As the revised arrangements, there is a national review now underway, which commenced from the publication in February 2023. We had reviewed ourselves against that report and are ahead of the recommendations, but we do believe there's more to do. We have a board development session with the Office of the National Guardian planned for November 2023, and we will continue with that cycle of improvement and that learning that we are taking from our new Freedom to Speak Up Guardian, who obviously has access directly to Peter and myself to talk independently about any of her concerns or any issues that she might find. And we are actively participating with the Department of Health and Social Care review into culture within the wider ambulance service across the country. That has commenced now, and we are expecting initial outputs from that by the end of October this year. So again, if there is any learning, we'll pick that up. And a lady called Siobhan Melia is leading with that. I know Sam's familiar with Siobhan and her work. The culture development plan is definitely prioritised within our organisation. It's a big word, isn't it, culture, and it's a lot to take forward. But at the heart of that, it's about how we treat each other as individuals. It's about how we are day to day and how we listen and learn from each other, and how we have that approach, which is big eyes, big ears, small mouth. And we have, you know, taken forward our quality improvement frame in a different direction now. We've appointed our Director of Strategy and Transformation to support us with that, and we have a series of roadshows implemented now to make sure that our staff all have that opportunity to speak directly to myself and the senior team, and we'll be conducting those on a rolling basis. We're working through colleague voice with our unscheduled care teams, and that is on a voluntary basis, but with time allocated for people to support us in bringing forward, because, you know, we know realistically sometimes people are more likely to talk to the person that they know than talk to us as openly when we go out and about. So we are working through that colleague voice, and that was an idea that actually came forward from one of our individual team members, and we thought that was great. So again, taking that forward with them. So a lot of work on that cultural piece. We're working on civility and respect. Our concerns around bullying and harassment, you know, have been outlined in our last staff survey. So a really focused effort to make sure that staff know that they are safe to speak up in the organisation, and that we will deal with any issues that they raise. And I think that is moving. Although it is early days in relation to that, and we'll know more, of course, as we continue with our regular internal reviews that we undertake, but also with the National Staff Survey. And our staff experience plan is being monitored through the Trust Improvement Group that I mentioned earlier, with Peter and John as our Senior Independent Director, holding us firmly to account in that frame, and obviously that reports into our Trust Board. And then we were asked to endorse the proposals for the commissioners, and Sam, you obviously said you would touch on those, and you know, we welcome the recommendations. I'd just really like to say actually we've worked really well with our colleagues in that commissioning frame over the course of the planning round just gone, and I think we're strengthening all of those arrangements now. We did settle to have an additional significant level of investment into the organisation. As I think I was saying openly to in my press interviews, that has allowed us initially to recruit another 50 frontline paramedics, 58 actually, with another 50 to come once the university outturn happens this year. We have sufficient funding to recruit an additional over 200 call handlers and clinical advisory support teams. That is more of a challenge. Call handling, recruitment is easy, but it's a tough job, and holding on to those people is difficult, and we do have a high turnover in that area. So again, something that we're looking at in detail. But that ability to take forward that recruitment, it just basically means there are more vehicles on the road. That increases our ability to respond in a timely manner. Because some of the cases, obviously, that are mentioned in Dame Marianne's report are to do with significant delays that we experienced in making sure that we were able to attend someone who was obviously desperately in need of us and needed us sooner than we were able to respond. So all of that is moving forward at pace for us. So our next steps, obviously we've got our public board meeting, we're here today, we've got our public board meeting on the 3rd of August. We've got our Council of Governors meeting also on the same day. We're representing at the Regional Overview and Scrutiny Committees so that we have an open and transparent discussion with our colleagues and stakeholders through the overview and scrutiny committees. We've got continued regulatory oversight through NHS England and our ICB colleagues. And our key focus in the next few weeks is to complete the review of the professional accountabilities, which are in recommendation 3, and bring those forward to the board. To understand when the Oversight Committee and family involvement will commence, so that we can play a full part of that and bring forward the details that the family would like to receive from us. To secure the medical examiner model and get that into place over the course of the coming weeks, and to hold our Nomination and Remuneration Committee to consider Recommendation 12, which is the backward view of those other cases linked to settlements. And then all the other recommendations, I would say, in relation to our assurance statement that we've given, are either completed or a long way underway, because we haven't waited for the report. I think it's important that we just stress that we haven't been sitting waiting for the independent report to be published. We have been working really hard in the background to make sure that the issues that we identified ourselves were being worked on and were being addressed, because that was the right thing for our population. Thank you very much.
Well, thank you very much, both of you. David, did you want to comment now or later?
I'll comment now, thank you, Salim. As part of the review, the ICB did its own assurance statement, and I'd just like to read that out if people would allow me. So, the North East and North Cumbria Integrated Care Board fully accept the findings of the report written by Dame Marianne Griffiths and acknowledge her work in investigating the serious issues identified. The issues raised precede the creation of the Integrated Care Board, and as such, the report recognises the transition of responsibility to the ICB on the 1st of July 22. Prior to this date, Northumberland Clinical Commissioning Group acted as the lead commissioner for the ambulance and patient transport services on behalf of the NHS across the North East. Following a number of quality concerns identified in 2022 as part of a whistleblowing process, the Shadow ICB instigated a risk escalation meeting jointly with NHS England. The outcome of this was to place the Trust into a quality improvement process led jointly between NHS England and the then Shadow ICB, in which the CQC also attends. This arrangement continued as the ICB was formally constituted and is continuing as part of an ongoing oversight. In addition, support has been provided to NIAS to strengthen its governance processes. We are assured that this has been a positive impact on the management of governance within the team, and the ICB will continue to review this as part of the ongoing oversight meetings. Since this time, the ICB has implemented new commissioning arrangements for the ambulance service within the ICB's executive team. Recognising there is a relatively new leadership team in place within NIAS, the ICB has secured well-led support through a buddying arrangement with Northumbria Healthcare NHS Foundation Trust, a trust rated outstanding by the CQC. The ICB also acknowledged the significant effort by the NIAS team to rectify the issues identified and is encouraged by the results of the most recent CQC inspection. We are confident such improvements will continue as part of the Trust's ongoing commitment to learn and improve. We can confirm that additional funding was secured in 2023 for the North East Ambulance Service. 8.6 million additional ambulance capacity fund provided by NHS England has been received. In addition, 18 million has been included recurrently in the 23-24 contract from the ICB. This level of funding was agreed with NIAS within this year's planning round and is based on bringing the organisation much more in line with other ambulance services across England. The ICB is committed to ensuring all NHS providers, including NIAS, are adequately funded to provide safe and sustainable services, and will work with NIAS to ensure that this is the case as part of the developing ICS medium-term financial plans, making the best use of the funding provided to the ICB by NHS England. The North East Ambulance Service leadership team continue to work hard to address the serious findings detailed within the report. The ICB will continue to support them alongside having oversight of their progress with the delivery of an improvement plan which was created to address the recommendations in the report and the CQC inspection findings.
Thank you, David. We said that we were going to discuss later on the agenda the follow-through action. So at that point, we'll ask whether the board wants to endorse that statement, that draft statement. Thank you. We'll open it up now to questions and discussion. Maybe I could start. You've announced, or you've identified a series of actions on improving patient safety. I've just got a thought on the context in which you're operating, or all ambulance services are operating, and that is that most of the development of patient safety in the NHS has occurred in hospitals, to a lesser extent in primary care. So in hospitals, whilst things can and do go wrong in safety, there's an established understanding of how the patient safety system works, and where the areas of risk are, where mitigation is needed, things of that sort. But it strikes me that there hasn't been comparable work in the ambulance services across the country. And I just wondered if, as part of the work that you're doing, if you are thinking of conceptualizing the field of patient safety within a service like yours, and because that's what will make it sustainable. A package of individual measures may be sustainable, but it would be much more sustainable if there was a general understanding by the leadership of your organisation and the staff what the dimensions of patient safety were in the service like yours, which isn't a facilities-based service the way that hospitals and primary care centres are.
Great question. It was one of the things that we discussed actually with Marianne when Marianne was conducting her interviews with us, because there is absolutely no direct comparator to even how we capture serious incidents, for example. So each of the 10 ambulance trusts captures those incidents in a slightly different way, and there is no overarching framework for that. So we have raised that already through ACE and the ACE team. So ACE is a membership body, for want of a better phrase to use, and we have commissioned a piece of work with them to start to look at that, so that we could make a recommendation to what I think will be NHS England chair, to say these are the measures that we could adopt. One of the things for me coming out of acute and into the ambulance service was I just expected to be able to compare apples and apples like I could in acute, and actually it is not possible to do that. So there isn't even a framework for never events, for example, in our sector. So I think it's a relatively big piece of work to conduct, but we have looked at commissioning that through ACE to make a recommendation into NHS England.
Okay, thank you. Sarah Malik is one of our primary care partner members.
Hi, thank you, Chair. I just want to add my humble condolences to the families affected, alongside the sympathies expressed by Sam earlier. Helen, my question was on the observations I made reading the report, looking at clinical governance, effectiveness, as well as quality and safety around the clinical classification of the calls. Obviously, in medical land, we understand category 1, 2, 3, but obviously to the residents and to our patients, they just want the help they can get as quickly as possible, and hence the classifications mean nothing to them. So I was just wondering if you had undertaken any kind of clinical governance or mitigating processes looking at if the classifications applied clinically were effective and appropriate. Basically, are they fit for function?
Thank you, Sarah. I mean, that's a tough one because they're nationally set. So the classification and all of the algorithms are set nationally. So we all follow the same process to make that as equitable as it possibly can be. From a NIAS perspective, the work that we have are undertaking at this moment in time is to make sure that we can clinically validate where we need to on a more frequent basis. So I'm sure you look at our performance reports at some stage, but within our performance reports, actually what we'd really like to be able to do is clinically validate more of those high-end category 2 patients. So by category 2, that's a response time within 40 minutes, but ideally within 18 minutes. This year we've been set a mean trajectory to attend within 30 minutes. So if we can work with, so Stephen Segersby, who's our Chief Operating Officer, is taking that piece forward, because we do think if we can clinically validate better, that would provide a safer service, because within that cadre, so category 1, response time in 7 minutes, NIAS is the top performer in the country. But for category 2 patients, there are 600 plus call outs per day. And some of those will be very low acuity, Sarah, as you know, and some of them will be very high acuity. So the work that we're doing is to look at whether or not the system and process that we can put in place from a quality and safety perspective will allow us to better validate those patients so we can pull those sickest patients forward. Does that answer your question? Thank you.
Eileen Kaner is one of our independent non-executive directors from a university background.
Hi, and I also chair the Quality and Safety Committee for the ICB. I guess we're really interested, I've heard a lot of the statements of the actions you're taking, but I guess I'm interested in what will be the enduring learning from this for yourselves and then for other partners within our system. But firstly, could I just say, I think the term whistleblower is a very unfortunate term. It's got a negative connotation, but unless somebody had felt safe to speak out about the incidents that they had seen and understood not to be correct, these problems would not have come to light, and then the actions you've taken wouldn't have been, taken forward. So I really do think that we need to be very, very clear about not just the fact that staff need to feel safe to be able to speak up, to have the freedom to speak up, and also to be a whistleblower if the need arises, but also they need to feel that it will be that they're heard. Now, I heard lots of statements there about ambassadors and guardians, etc. So there's a new cadre of individuals within the system, but how will you know, looking forward, if all of these actions have actually led to a deep sort of seated cultural sort of change? And yeah, perhaps that's my question. How, putting all that in place, but how will you feel yourselves confident that all of those actions actually will address what looks to be quite a long-standing and deep-rooted situation for the Trust?
Thank you, Erin. I mean, I think that goes to the core of the cultural work that we're undertaking. I absolutely agree with you that the term whistleblower has got negative connotations attached to it now, which is really unfortunate. And you're absolutely right. If our whistleblower hadn't come forward and told us, we may have picked those up at a later stage, but actually we can't sit and guarantee that would have happened. I suppose what I want to say in terms of that is a good example of where we did act. So I can only speak for me and my team as I came into post. So when we met our whistleblower and he raised his concerns with us, I raised those immediately with the chair so that we could acknowledge him as a whistleblower, to thank him for bringing forward the issues that he did bring forward, because that allowed us to take the action that we took. And as you say, without that, I don't know. I can't say would we have found things or would we not. I like to think that our approach as a team coming in, and my approach and the board's approach, would have allowed us to push that forward. But the timeliness of that would have been slower, Eileen, no doubt. In terms of the enduring legacy, I think that is a really important thing. So for me, personally, we have to hold those families in the heart, at the heart of everything that we do. And when we are thinking about the triangulation of the work that we do, from both the culture, from our audit, from our board assurance, from our freedom to speak up guardians, and any other areas that we can triangulate, our staff survey, for example, that we can clearly show, not just from a numerical perspective, because you could say, oh, we've had, 10 people come forward to tell us something under freedom to speak up, but actually it's not the 10, it's what you do with the 10. It's how you learn from it and how we bring that forward. Some of that will be anonymised, of course, so we have to be careful about protecting people's confidentiality within that, but the board is very clear on its triangulation to make sure that the cultural elements are triangulated with the measurables, so that we hold that frame moving forward.
Just to add to that, I think just to reiterate what Helen said, when the individual did come forward, we were really clear that there was something not right here. And I wanted to make sure that we commissioned a NED-led review of the coronial processes, and that was very deep and very broad, and actually discovered a lot of the things that we now see in front of us. So I just wanted to make that really clear to this board this afternoon. Secondly, I think on how do we know, it's a mix of both quantitative and qualitative. If we ask the right questions in pulse checks and in staff surveys, I'll say that again, if we ask the right questions in pulse checks and staff surveys, we will get some empirical evidence. But we also have to add to that the triangulation piece of what do people say to us, and that's particularly true from a non-executive point of view, because my experience as a non-executive would be that eventually people will tell you things when you're out and about on observation shifts. Again, if you ask the right questions, and you can start to piece together that body of evidence between what you're being told from staff surveys and pulse checks and what you're being told actually by people on the ground. And then the third leg of that three-cornered stool, if you like, would be what are our patients and what are our communities actually saying about this, and does it feel different? So I think we will know. When we will know might be your next question, and I'm not going to be able to put a finite response on that, but I think we will know based on those three things.
David Stout, another of our independent non-executive directors and chair of the audit committee.
Hi. Not surprisingly, the national report that's issued, has captured the media interest. And a few days ago, in The Guardian, there was an article, and within that article there's an accusation that under FOI, that you'd refused to issue an interim report carried out by Audit 1, and the reasons given was it was an interim and also contained personal information, and I can understand the logic of that. However, it also said that within the structure of decision making as to whether a document should be released, that a person who had been named in the interim report was empowered and made a decision not to release it. And to me, that looks as if there's a conflict there, and I wonder whether that is true. And if it is true, why that was allowed, because that would appear to be a conflict to me.
Thank you, David. So in relation to the interim report and the fact that we haven't published it, that is the reason, because obviously there are staff identifiable details in that interim report. And if we go back to the heart of freedom to speak up, people will not speak up to us if we do not respect their confidentiality. So we hold by that in relation to that report. The person who is being referred to in the Guardian press, it is one of our team who, if we go to appeal, views the appeal process for us. So that is correct, that person is involved in that appeal process. And I think it was fair challenge to us as an organisation. It was made to us as part of the Freedom to Speak Up appeal. So behind all of that, we have independently reviewed any of the decisions that were taken by that individual and are comfortable that those decisions were fair and just. But I do think there is a learning element for us around how we make sure that that is as independent as it possibly can be in these situations where an appeal is lodged.
So can I just follow that up, Jim? So as I understand the last thing you said, so under the FOI, was the organisation generally at a higher level aware that this report was not being issued for the reasons that you said, it was an interim, etc.,
Yeah.
and that it wasn't an individual who made that decision at another level in the organisation?
Yeah, so the process, David, ultimately is that I have to sign that off.
Right.
If it's not, if we are making a decision not to disclose, that is in the Chief Executive's domain. So the proposal will come to me. I will fully review that and decide if I'm comfortable with that direction. But that is a CEO responsibility at appeal.
Thank you very much. Thank you.
John Rush is also an independent non-executive director.
Hi. Just when you gave the presentation, you talked about individuals who had amended reports for the coroners, and you described them being treated in a just way based on the information you had. So my question is why did you decide to treat them in that way rather than in a misconduct way? So I'm just trying to understand, because you did say at some stage we may allude a little bit more to it. So I'm just really interested in why you made that. If it was your decision, Ellen, or somebody else's decision, why was that decision made in that way?
Yeah, thanks, John. I mean, some of that process was in train before I picked up the organisation. But of course, we've got our own internal policies and processes for review of any individual case. And also there are ongoing professional conduct issues to be considered. So it's difficult. I can't obviously comment on any individual, but what I can say are two things. I'm comfortable that our own internal policies and processes were followed to review that. We have agreed that we will go back and just check and balance those and bring that to the board to make sure the board are comfortable with the historical decisions that were taken at the time. But secondarily, there are a number of professional reviews that are still live at this moment in time, so they may conclude that further action needs to be taken. So when you are in a process like this, obviously it puts a hold on some of the decision making that you would have taken forward as an organisation. So when they conclude, there may be some further action, but I don't know what that will look like at this time, John. Thank you.
Sam.
Thank you, Chair. Helen Peter, my question builds slightly on Eileen's point, which is when we look at the report and with all the work that we've done alongside and with you, when we go right back, one of the issues that was picked up when the concerns came to light was the low level of reporting of serious incidents at the North East Ambulance Service. And I just sort of was minded of the presentation we as a board and a whole health system had from Dr. Bill Kirkup on the lessons from the East Kent maternity review and his point around what he calls failure to read the signals, and the curiosity. So I'm curious in terms of your board work and the sort of, Peter, you described the quantitative work, how you're now benchmarking yourself against other ambulance trusts, so that there's a more perhaps proactive approach to support your assurance as an organisation on how you're performing across a range of areas, obviously including safety.
Thanks, Sam. I think, so from a board perspective, at every board meeting we look at benchmark data on all aspects of performance. I think the one counsel I would say about SIs is, as Helen referred to earlier on, there is no consistency, even now, in reporting serious incidents across the 10 English ambulance trusts. That's something that I think, as a result of this work, and particularly the work that we're doing on implementing PSERF, as Helen referred to, on implementing the arrangements with medical examiners in an ambulance trust for really the first time nationally, that we'd want to try and lead the way on. But I think it's quite instructive to look at the category 1, 2, 3, 4 performance standards, because, as Helen said in response to Alan's question, those are national standards. It is not yet instructive to look at serious incident comparisons. Is the board curious enough? I think the board is curious enough, considering the changes that we've made and the additional clinicians we've brought onto the board. And I think it's really important that we've now got a director of quality and safety, we've got a director of paramedicine, and we've got a medical director. And particularly director of paramedicine, we can start to make those compares and contrasts across the different organisations in a way that we probably weren't able to before. And I think, given the strengthening of the board that we've done in the non-exec cadre over the time that I've been chair as well, we are now a much more curious board than either of us had seen back in 2018, 2019. But I don't think we're at a position yet to be able to benchmark SIs against other ambulance trusts for the reasons that we've said.
Just one final question from me before we conclude. I mean, you've talked about engagement with patients and families as part of your response to the investigation report. Have you given any thought to, again, this is a question of sustainability, integrating patients and families more into the running of the organisation so that they're involved in giving views on the design of services, the development of services, as well as the safety side of things?
Thanks, Liam. Yes, we're definitely working on that. So we do work with patient groups. For example, when we redesign our vehicles, actually we will go out to numerous patient groups to say, is this going to be fit for purpose for you? And our dementia-friendly ambulance was a design that was adopted nationally, and we did that with patients at the centre of that, and they actually helped us to design that. There are two or three other things that I think that we can do. So the establishment of a patient voice group is quite difficult for us, given the geography. So we are looking at how we might tap into everybody else's, if we possibly can, and think about how we might get some voices through there. We are working through the board cycle to make sure that opportunities for families to represent and bring their own cases to board are offered, and that's obviously part of our learning, and we are bringing our patients into all of the design aspects for things like our vehicles, for any changes that we might make. For example, so as we're working with our mental health colleagues, if we want to develop a different type of service of mental health, we will be engaging with TÜV and with CNTW on how we draw the patient voice into that. I think it has been an area of weakness for us, Chair, if I'm really honest, but I think there is an opportunity now for us to close that down.
Well, thank you. We'll conclude this agenda item now. As I mentioned earlier, later on the agenda, we'll just confirm the follow-through action from the ICB point of view, including picking up the points in David's draft statement. But for now, could we thank you very much for coming this morning, Peter Strack and Helen Ray, and for giving such a thorough presentation and answering all our questions. So thank you very much indeed. We move on now to the Neil's item on the agenda, and Neil, I think you've got a presentation to start off with.
Yes, thank you, Chair. So I'm just going to very briefly update the board on the progress that we have made with the now we've concluded the spring booster campaign for the COVID-19 vaccination. I want to start by thanking all of our providers across the North East and North Cumbria, a really enthusiastic group of general practitioners, community pharmacists, hospital delivery, and also the work of our Strategic Vaccination Coordination Centre in dealing with some of the challenges which I'll outline in this presentation. Our key points for learning are that vaccine supply is our #1 risk in rolling out the vaccination programme. This has attracted a lot of complaints to the ICB from both members of the public and from MPs, which we have responded to, and we've taken learning from, particularly around rural access to vaccination and having timely access and appointment availability for the public. I'd like to pay particular attention to our communications campaign, which I think is every year gets better and better around both the vaccination for COVID and how it links in with other seasonal vaccination, which is mainly flu, and there's a little bit more on that in the presentation later on. We've done further work on integrating seasonal vaccination programmes with the standard vaccination schedules, and we are preparing for that function that will at some point come over to the ICB. But we've worked in an integrated way with NHS England for a number of years now in both the Strategic Vaccination Board and place-based vaccination boards in each of our local authority areas. And the other key point of learning is data. Data is absolutely critical for us to understand exactly where the areas of uptake are greatest and not so great, to understand the health inequalities that we have in access to vaccination, so we can plan our vaccination programmes much better in the future. That being said, these are I've just provide you with some data from our kind of our highest risk populations, which are care home residents, the 75 years and over, and the immunosuppressed from the spring campaign. As you can see, that the North East and North Cumbria has pretty much across the board certainly achieved on par, if not greater than, the NHS England average and the North Eastern Yorkshire average, which is encouraging to see. The next slide, I'll circulate the presentation later. I know some of the numbers are there. That just really shows you the granularity of the data that we actually have. But something on deprivation. The system average uptake across all cohorts was 66.8%. Now, the deep end practices are practice populations that are in our most deprived populations. And as you can see, this slide says there is still a difference in that the average uptake across all cohorts was 60.4%. That is still an unacceptable difference. We'll work with data, we'll double down on our campaigns, but that gap is narrowing compared to the autumn 22 campaign. But that's not just seen in seasonal vaccinations, that's all of our vaccination cohorts. So we'll use the learning to look at the entire vaccination schedule. Unfortunately, ethnicity, if you look at the reduction in uptake in 23 compared to 22, those in ethnic minority groups saw a greater reduction. And part of our behavioural insights work is to understand why. Why is that? And we'll bring that learning forward as well. I mentioned vaccine supply. It has been the biggest problem this year, and it's injected risk in a number of ways. One, in that it has disengaged some of our providers, where they've had to sometimes cancel vaccination clinics at relatively short notice, which is disruptive for both patients and our providers. We did, for the first 11 weeks of the campaign, we had 24% less vaccine in the system than we did in previous vaccination campaigns, and the first 2 weeks only vaccine delivered that was suitable for the over 75s was available to give. It meant that some of our, as I mentioned, our providers, community pharmacy, couldn't deliver on some of their appointments, and it did lead to invariably a level of reduced uptake over the full 12-week campaign. That being said, we did deliver the housebound vaccination and care home vaccination at a faster rate than previous campaigns, and they are amongst our most vulnerable. But we were short by some 40,000 vaccines by week 6. And part of the function of our Strategic Vaccination Coordination Centre is to actually move vaccine around. So we were able to still continue to vaccinate by coordinating the movement of vaccine across the North East and North Cumbria, which is a vital function that we'll have to continue in future campaigns. This is just some visuals on our campaign, and as you can see, there was a great reach across all forms of media. We had 10 MP inquiries that came in and 7 patient complaints that we all responded to and have taken the learning and will incorporate into future campaigns. So my last slide is that, so what can we do to try and meet some of these challenges? We have submitted a pilot proposal that would see the North East and North Cumbria get 75% of its total vaccine up front, and then we will manage the vaccine supply. So that proposal has been submitted to NHS England. Both myself and Sam have met with the national team and informed the national vaccination strategy, taking some of the learning that we've had from the North East and North Cumbria and incorporating that into that national piece of work. We'll continue to learn from the behavioural insights, and we've commissioned more behavioural insights work into what are the barriers to vaccination, and we'll incorporate that. We'll go double down our focus on some of those harder to reach groups and continue our integration, and we'll bring further updates to the board once JCVI have agreed the form and structure of the winter vaccination programme, which we're expect probably in the next few weeks. Okay, thank you.
Okay, Neil, thank you very much indeed. A very clear presentation. Any comments or questions? Syra.
Thank you, Chair. It was just a question for Neil with regards to the ethnic minority groups. I remember initially as a GP when we were delivering the initial vaccines from 2021 onwards, we assumed that there are no hard to reach groups, only that we haven't found a way to reach them. But we were providing buses into our communities, we were going into the mosques and the temples. We really were using a plethora of innovative ideas. And I just wanted to seek clarification if we had continued to do this, or just due to the constraints of the workforce, whether we'd had to change the way we were delivering vaccines.
We continue to commission 4 or 5 roving models. So that's buses that go into communities, and we've used that approach to some of the ethnic minority groups going into their communities and also rural communities, and we plan to continue to do that in future vaccination campaigns.
Mike.
Thank you, Neil, for a really clear presentation, and I would second all of the recommendations, having been quite closely aligned to this work. In particular, I think it's great that you've picked up on the vaccine supply being a very significant issue. I also think it's really a credit to the work of your team, really, that our performance is so high. Thank you.
David.
I just wanted to thank Neil for the report on the presentation, and good to see the focus on health inequalities. That was really helpful. I couldn't see the numbers, unfortunately, but that's probably my eyesight problems. But I think I got the gist. You talked about sort of trying to understand more about what we can do in terms of getting better reach, if you like, into more challenging areas. Is there any work going on in terms of learning from other areas, other parts of the country, where maybe they're having great success or not? Is there a way of sharing that information?
Before you say anything, Neil, I just wanted to jump in because I've raised several times the concept globally in other parts of the world they very strongly, for vaccination, use people called social mobilizers, who are normally members of the community of the sort that I mentioned earlier, who would go and talk to the parents, go to the houses, knock on door to door, and it makes a huge impact on vaccine updates. Not a tradition in this country, but I think in our ICS, we would have the opportunity to bring something like that in as an innovation, possibly in 1 or 2 communities to begin with.
And I agree, and we have done that, but probably not in the scale that we could. So we've certainly worked with certain faith leaders to go into Muslim communities that have low uptake levels to try and be those champions. But I think that is an area that we could do more on.
On that point also, I was wondering what our engagement with the voluntary sector is on that front, if there's any groups that we can link in through to those communities through.
Yes, so we have voluntary sector representation in our strategic advisory group, and they also are represented and work closely with our providers in the place-based vaccination groups. There's always room for improvement, but they are engaged in this work.
Okay, thank you. Before we move on, can we go back to the ambulance service report and ask Sam to highlight the follow-up action? I'm conscious that David's statement was quite detailed, and it's obviously a lot of hard work gone into that. But we are, as a board, I think we have to formally agree it, and so I'll open up after you've commented to see if anybody has any thoughts or views on what they've heard and whether they want to modify the approach that we're proposing you take in any way.
Thank you, Chair. The only point I really want to sort of pay reference to is the establishing the Independent Oversight Board. So we are working with NHS England, one of our 2 regulators, on this. They are identifying a chair. We hope that they will be able to confirm who that chair will be in the next couple of weeks, and subject to that, I'd be optimistic that we would certainly be able to hold the first meeting in September or October at the latest, and that group would run for a minimum period of a year, and certainly until such point in time as both the North East Ambulance Service and ourselves, the 2 actions we've got, are able to demonstrate and provide full assurance that everything has been completed to a satisfactory level. That the only proviso for that will be the family involvement as well in that, which we've got further work to do in order to ensure that they are able to participate in that group in the way that they want to. So my proposal, Chair, is that we bring an update on progress to this board in 6 months' time, unless by exception there's anything we need to ensure the board is fully appraised of with regards to the implementation of that report. And then just secondly, I do think we have a role as the Integrated Care Board for the North East North Cumbria to, as I said earlier, not only ensure that the North West Ambulance Service has taken on board the lessons from this, but also we extrapolate the relevant recommendations that have got relevance to all of our NHS organisations. And my proposal is that we work closely with the provider collaborative that represents the 11 foundation trusts across North East North Cumbria to agree a way to do that. And I know our Quality and Safety Committee of this board would have oversight of that.
Okay, so having read the report and had the discussion this morning and listened to David and Sam, is there any other action that anybody would want to recommend for us to take? John.
I don't know if it's a specific action, but one thing about the medical examiner role, which really interests me, is one is obviously it's within acute. You know, I don't know if it's in mental health acute. That's the first question. It might be, might not be. And secondly, how relevant is that kind of role within primary care? as well, or not, in terms of supporting practitioners. So there's just something about that I just wonder whether or not it is important. It's already done or it needs to be done. I don't know.
It was actually one of my recommendations as CMO, but it took about 12 years to be implemented and was modified away from what I'd originally proposed to a certain extent, because I'd wanted it to very much be community based, and so, for example, look at deaths from hypothermia and be able to make different sorts of recommendations about preventable deaths. But we'll get to a clarification on that for you, because I think that element of it was quite an important ingredient in what they were proposing. So we'll come back, John, and give more information on that. Ken.
Can I just follow up that comment on the role of medical examiners? A lot of organisations are now already focusing on deaths in the community, not just primary care in the community, as part of that process already. So that's underway in organisations, to answer John's question.
Okay, thanks.
Eileen.
So it's not about the assurance statement, which I have nothing to add to. It was just one unresolved issue. I think I saw, well, Helen mentioned the issue of restorative justice, and part of that is an opportunity to be heard. I think I read in the report that at least one of the families involved felt that they would want the details of that case to be used in specific learning for, you know, training and learning purposes. And I don't know that we covered that when we were in the kind of wider discussion. But in terms of that sense of restorative justice, it's not just, have you heard me? And those opportunities to take part in that process. But I think there was that comment about at least one family would want the details to be a specific learning case. And I think, Sam, you asked about how the families were going to be involved in the process of improvement. And I think that's just one area.
Yeah, and there's a theme there with another one of our provider organisations, Tees Escombe Weir, Eileen, and we are working, having some very early discussions with a charity called Making Families Count, who do specifically work with families to develop their experiences as case studies for wider learning opportunities across the NHS, and we could certainly add that bit of work to it as well.
Okay, thank you. And we'll add in those extra dimensions. We'll give you the progress report in 6 months' time, but presumably the Quality and Safety Committee might be discussing some of the work as it goes along anyway. So that's an extra assurance for us. But thank you, and thank you particularly, because I know Sam and David have been very close to all of this and done a lot of good background work on it. But and thank you for the discussion earlier. I thought it was a very full and searching review of the response to the report. We're going to go fairly quickly through the remaining items. So if anybody feels afterwards that we've glossed over or rushed through anything from the committees that you felt you wanted to spend some time on, flag it up with Claire, and then we can follow up and get a discussion with the committee chair and ensure that you're reassured if there's anything that you're concerned about. So if we move first of all to the executive committee. I'm sorry. It's the governance handbook.
Thank you, Chair. The updated governance handbook is in front of you in the papers. This is issue 7, therefore people will be familiar with the format of the governance handbook. Just to reiterate, it's important that this comes here on a regular basis to make sure that it is fit for purpose and it is representative of our governance and how we operate. We are seeking for approval for this new edition, and there are some material changes that have been detailed within the report. Very quickly, I will highlight the changes which are HR policies, and that is linked to the approval moving to the executive committee rather than this board, just to make sure that we don't fill up this board with unnecessarily approvals for HR policies. It also now reflects the additional responsibilities that we took over regarding pharmacy, optometry and dental. It reflects some amendments to the financial delegation limits for care packages. It amends the executive committee terms of reference relating to a job title change of an executive. There are some minor amendments to the Remuneration Committee to reflect some portfolio changes, and it also reflects the ICB committee structure, in particular some of the subcommittees of the board. Happy to answer any questions, Chair.
Are there any questions? No, I think we can move on. So on the next items, I'll be guided by the committee chairs as to how much discussion or how much talking they're going to do on this now. But over to you first with the Executive Committee, sir.
Thank you, Chair. The report covers the highlights of the meeting in May and June. I do just want to draw out two items, and one of them to flag a risk issue with. The delivery of prescribing efficiencies. So the two main areas, and this links to the finance report on the agenda earlier today, where we would be looking to make efficiencies would be in prescribing and also in continuing healthcare. We've had some very detailed updates on both to the Executive Committee. The point in today's highlight report with regard to the prescribing efficiencies, for me, highlights both the variation, but also whilst we can be clear on the steps we're taking to influence prescribing practice, the one area that's completely outside of our control is the cost of medication, and we know there's been a lot of volatility in the markets related to this and the impact on the concessions the NHS can achieve. And in fact, Chair, I do think this is something we should have a more detailed item on in public later this year to fully understand both the actions we're taking around prescribing and the cost impact. We also, the COVID medication delivery units, so these were established to enable the distribution of antiviral medication to people eligible for that. It was a service that was funded nationally, funding available. That funding has been withdrawn, and yet the expectation remains that we need to be able to ensure our population that's both eligible and meets the criteria can access this. So we're still working through. We haven't decided to withdraw the service at the current point in time, although the current providers do not wish to continue delivery of this service into the future. One of the factors here also is the whole way in which COVID-19 is tracked and monitored nationally. And previously, where people were submitting tests for this, using things like the NHS app, the identification of individuals, and there's a certain time limit where they can access this medication, was far easier than it is now. So we will keep this item under review. And the two further points in the highlight reports, the joint forward plan development, to note that, as I said earlier today, that's out of consultation, and some very extensive work that's been undertaken and is underway in our Tees Valley, looking at the palliative and end of life pathway, part of which is provided by the hospice sector. Quite a lot of it is provided by our NHS organisations and also in people's own homes.
Okay, any comments or questions on that? Eileen, on you got your flag up. If there are no comments or questions, then it is you, Eileen, on the Quality and Safety Committee.
Yeah, thanks, Liam. Just to say, we met only 5 days ago, so the summary slide is hastily done. This committee took a skip in order to get in time with finance, performance and investment to make sure we were seeing data at a roughly sort of similar point in time. So it was our 5th meeting. I think the item we've had on NEAS, the North East Ambulance Service Trust, really highlights the critical role of the quality and safety processes and the staff and the data that we see. I think it's fair to say that the Quality and Safety Committee structure was in place before the area arrangements were completely in place and bedded in. As I say, during the pandemic and as the ICB was coming into view, I think there was variation in areas in terms of whether some local quality and safety committees continued to meet or actually took a pause in their arrangements. We have 4 area nurse leads now who come to the committee, and they play a prominent role, an increasingly prominent role at the committee. I think we need some further work just in terms of standardising the information they report and the way that they report the information. Just to give you some sense, our papers included 622 pages of information at the last committee, and that's quite a lot to work through, and it is a risk in a way in order to be able to see the wood for the trees. So we really just need to try and make sure that we have standardised and streamlined ways of reporting, and particularly so we can see key risks, actions taken to address risks, and having assurance that actually those actions have led to a change in the risk status. The other substantive items, I think the voice arrangements, the arrangements for listening to public and patient voices and perspectives are maturing rapidly, and we had a substantive update on the voice subcommittee arrangements, including patient voice around maternity, etc. And we are working to really trying to begin our quality and safety committees with the stories from our patients and our public, so that we can really kind of bed our activity in real lived experience and not just the information that comes in paper form to us. I think the other thing to say, and you'll notice from the previous item, I think there are 7 subcommittees listed under the Quality and Safety Committee. I believe there's a dotted line from the Medicines Committee also, and we took 2 items where there was a recommendation for a special educational needs and disability, assurance subcommittee, and also a clinical effectiveness advisory group to be recommended, so that we could know where we're up to in terms of NICE guidance and how we are adhering to NICE guidance. That's a lot of subcommittees under the Quality and Safety Committee. So I think the document with the governance structures probably needs to be updated once again, and just to really flag there's quite a lot happening there. But I think I'll leave it at that.
Anybody want to raise anything on Eileen's report? Thank you. John.
Thank you, Liam. Just in relation to the items there for performance, I'll leave with those first, actually. We've heard some of those things already during the presentations that we've had from Jacqueline, but obviously there's some positive stuff in terms of movements from different tiers for North Cumbria, balanced against a sort of segment movement for Newcastle, downwards as it were, but also as well some positivity around the Cancer Alliance Assurance meeting, that we got full assurance for that. So I don't want to touch much further on those in terms of performance, but one of the things I just want to touch on there was about the children and young people mental health waiting times. And I think it was quite useful in terms of where this originated from. I think some work being done on Jacqueline's side and David's side, some work being with the committee. It was Rajesh who raised it in our meeting, who's obviously our mental health rep. So those two things coming together at the same time was really important. We're still waiting to get the outcome of that. I know there's a lot of problems in just trying to get all the data, which proves how difficult it is. But I'll be really interested when we receive that report. And I know it's going to go to the subcommittee first of all, Levi, which is fair enough, but I'm really interested from the committee's perspective when we get that. As regards the financial side, again, David touched on some of the issues that we're facing, but I think the biggest things for us as the committee is what's going to be contained within that mid-term financial plan, particularly to try and mitigate that, well, should we say, balance up that unmitigated risk of £102 million. That's a massive challenge for us as an ICB and a massive challenge for us as an ICS. But I finally wanted to finish with some things that aren't on there, which probably came out of the conversation we had yesterday in the meetings that you pulled together, Liam. Just one of the things we had concern about as a committee was when we looked at our role within investments, because we are financial performance and investments, we were finding we're doing very little. I think from the conversation we had and some of the proposals put forward by Sam, in that we would take a much more, should we say, oversight of investments, because most of them are done at executive committee, and we had that conversation. So we're really interested to see what comes forward from that, so that we get an oversight of that rather than just potentially receiving the minutes as we do now at this particular meeting. So that was one of the things. That also as well, where I think we came in very useful as a committee was where there was various options put up for sharing out of some funding that's available across the whole of the ICS, where in the past it was individual CCGs maybe agreeing these things. We were able to, as a committee, give that oversight of say, okay, We can't get all the providers to agree on what the options should be, but there's the options. And then we would get a recommendation that would come forward to us, and we would make a decision as a committee about how to divide that up, which I think is a good way of cutting through some of the things that perhaps we weren't able to do a while ago, particularly when we had, again, as the ex-chair of the joint CCG committee, you just couldn't do it because you had to get agreement from all the CCGs. So it was a really positive thing, I thought, for the committee to be able to have that oversight across the whole of the ICS when required, is probably what I would say on that. A couple more things. I think there's still some work to do on what it's going to look like within the integrated performance around the optometry dentistry pharmacy piece, of course, both financially and both performance-wise. But I did want to commend Jacqueline and the team for the integrated report that has been constantly evolving, and I think we're getting to a stage where it's a lot better and a lot clearer about how we can do that. And then finally, just to mention, again, it came out of yesterday's discussion, the different remits of each of the committees. We've commenced some work to say, let's try and avoid duplication where we can, but also at the same time, we do realise that there could be some duplication because it's just the nature of the beast that we've got. And I think the biggest one is between probably the exec committee and the finance and performance investments committee, where the not duplication, but where just clarifying exactly what it is that we want to do and what the executive want to do to make sure they fit in with everything. So that's where I wanted to leave it, really. Thank you.
Okay, thank you very much. And I think it's at some point it would be very useful, as we've been going for a year, to get the partner members' view on the committees, because you don't have as much direct involvement with them because they're chaired by the independent non-executive directors. Sam.
Thank you, Chair. It's just a question for John as Chair of the committee. So we're just over a year old and we've been establishing a lot of new ways of doing things, and the integrated performance report I think has come on leaps and bounds over the year. It's a sort of constant iteration, and one of the things I know that we've done now in the integrated performance report is get a more holistic view of things like CQC ratings. So I think it would be fair to say in our probably first half of the year we had an over-emphasis on NHS organisations, but we can now see that we're tracking general practice, residential care and social care providers, and we've also done some work to set up a social care forum. I suppose I just want to ask, as the committee got into, we've got 7 of those types of services rated inadequate at the moment, just in terms of what our improvement focus or support would be into those parts of the system, or is that a sort of a next piece of work of the committee?
We've done we get some information and we get told what's happening and we get told what the plan is. For some of those organisations that are not NHS, the committee has not done anything other than go, we've got one of these that's rated as inadequate. But that's probably about as far as it's gone, Sam, to be honest, at the moment. And I think we've probably only had that information, I might be wrong, probably for the last 2 meetings, I would suggest. Yeah. But it was useful to see it. In the first instance, what we do with it is we've not done a lot at the moment.
Yeah, thank you. I'm keen not to run really late, but if there's any, Jacqueline, if it's a very brief comment, please go ahead.
Well, I was just going to make the point that the integrated development delivery report serves all of the committees, and one of the issues with things like the CQC ratings is it a matter for quality and safety? Is it a matter for finance and performance? So I think it might be worth us doing a bit of work, almost aligning the elements of the IDR to specific committees. Because whilst it's useful to have that kind of holistic view, the kind of deeper dive needs to sit in one place. We've done a bit of that, but we maybe should work through comprehensively and just check there's no areas of lack of clarity in relation to that. So happy to take that on as an action.
My clinical skills are very rusty, but I can see some trembling with hypoglycemia. So we'll just have the final. We'll have the final item then, Claire. I'm going to assume there's no other business. The questions from members of the public.
Yeah, there is a question from a member of the public. There are 3 parts to the question. It does relate to sub-services regarding abuse and sexual abuse. David Perdue is on developing a response to this. The response will be emailed back to the person who has asked the question and will be made available on our website. David, I don't know if you've got anything further to add.
No, just because it's not related to the agenda today, we'll write formally to the person, but the response is finalised, so it can go.
So it's being followed up. Good. Excellent. Well, thank you, everybody. It's been a long meeting, but we've covered some very, very important subjects today. And I do value very much the contributions you make to the discussion. It greatly enriches the papers and the presentations that are made. So thank you, and look forward to seeing you in between now and the next meeting, but at the next meeting, definitely. Okay, bye.